بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على المبعوث رحمة للعالمين سيدنا محمد وعلى آله وصحبه أجمعين. يقول الله سبحانه وتعالى: من عمل صالحا من ذكر أو أنثى وهو مؤمن فلنحيينه حياة طيبة ولنجزينهم أجرهم بأحسن ما كانوا يعملون. فإذا قرأت القرآن فاستعذ بالله من الشيطان الرجيم. صاحبة السمو الملكي الأميرة نورة بنت محمد العبد الله الفيصل، أصحاب السمو والمعالي والسعادة، السيدات والسادة، ضيوفنا الأعزاء، أيها الحفل الكريم، السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. يسعدني أنا خالد الشامي مقدم الحفل الافتتاح، ويشرفني أن أتقدم بالترحيب الحار بكم جميعا ونيابة عن اللجنة المنظمة في حفل افتتاح منتدى سياسات صحة المرأة الذي تنظمه جمعية رفيدة لصحة المرأة بالتعاون مع هيوستن ميثودست لخدمات الرعاية الصحية العالمية، والذي يعقد هذا اليوم 3 فبراير من عام 2024 هنا في فندق الفور سيزونز بمدينة الرياض، ونتمنى لكم فيه كل التوفيق والخروج منه بتوصيات تحقق كل ما تصبون إليه ونتطلع له في هذا المجال، وتحقيق هدفه الأساسي المتمثل في القيام بمراجعات وتقييم للسياسات والممارسات والتطبيقات الصحية الحالية، مما يستلزم خطوات تطويرية وتحسينات تساهم في النهوض بصحة المرأة. وسيكون المنتدى بمثابة منصة تفاعلية سيقدم فيها خبراء رفيدة أبحاثا تتناول القضايا الرئيسية المتعلقة بصحة المرأة وحقوقها الصحية، بهدف صياغة توصيات تتماشى مع سعي المملكة ورؤيتها في تعزيز الرفاهية الفردية والمجتمعية. Your Royal Highness Princess Noura bint Mohammed Al Abdullah Al Faisal, Your Highnesses, Excellencies, ladies and gentlemen, Assalamu alaikum wa rahmatullahi wa barakatuh, and good morning. I am Khalid Shami, your MC, and I have the honor to welcome you on behalf of the organizing committee to the opening ceremony of the Women's Health Advocacy Forum. This significant event is organized by Rufaidah Women's Health Organization in collaboration with Houston Methodist. This event is taking place here today, the 3rd of February 2024, here at the Four Seasons Hotels in Riyadh City. Your Highnesses, Excellencies, ladies and gentlemen, the primary objective of this forum is to conduct a thorough assessment of the current health policies, practices, and applications, necessitating substantial development, strides, and enhancement. As a vital component of today's event, the forum will function as an interactive platform, as the Rufaida's recognized researchers and experts will present researches addressing key issues related to women's health and health rights, with the overarching goal of formulating recommendations that align with the Kingdom's visionary pursuit of promoting individual and societal well-being. أصحاب السمو والمعالي والسعادة، ضيوفنا الأعزاء، نبدأ حفلنا بكلمة ترحيبية من سعادة الدكتورة فاطمة بن سعيد الهملان، رئيس منتدى سياسات صحة المرأة. Now we will begin our ceremony with a welcome speech by Dr. Fatma Al-Hamlan, chairperson of the Women's Health Advocacy Forum. Please.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. صاحبة السمو الملكي الأميرة نورة بنت محمد الفيصل، أصحاب المعالي، أصحاب السعادة، سعادة كاثي إيستر الرئيسة والمديرة التنفيذية هيوستن ميثودست لخدمات الرعاية الصحية الدولية، الحضور الكريم، السلام عليكم ورحمة الله وبركاته، وأسعد الله صباحكم بكل خير. نلتقي فيكم مجدداً وللمرة الرابعة في منتدى سياسات صحة المرأة. هذه المرة المنتدى بتعاون نوعي دولي مع هيوستن ميثودست شركائنا، اللي هذه الشراكة استمرت لأكثر من 4 أعوام. نتج عن هذه الشراكة هذا المنتدى النوعي الذي يركز على العافية قبل التعافي أو العافية قبل المرض. أيضاً من ضمن هذه الشراكة موقع إلكتروني أنصح الجميع بزيارته، نهدف أن يكون هذا الموقع مرجع للمعلومات الطبية الموثوقة وباللغة العربية، لأنه هذا اللي نفتقده دائماً في المملكة. ولأن الأبحاث العلمية خاصة في صحة المرأة مستمرة ومتطورة، نحتاج أن نواكب هذه الأبحاث لتنعكس على السياسات الداعمة في المملكة العربية السعودية. اليوم نجتمع لمناقشة 6 محاور مهمة في صحة المرأة. هذه المحاور وهذه التحديات الصحية وصلتنا من السيدات من المجتمع. دورنا في رفيدة كمؤسسة مجتمع مدني أن نتلمس احتياج السيدات في المجتمع، ونجتمع مع خبراء رفيدة ومع صناع القرار، وأيضا مع الخبراء في القطاع الغير ربحي، القطاع الربحي، وأيضا القطاع الحكومي، لنطور هذه السياسات ونخدم المرأة في المملكة العربية السعودية. فاليوم سيقدم خبراءنا الدراسات ومرئياتهم لتغطية السياسات الداعمة لصحة المرأة. حضورنا الكريم اليوم، أنتم كصناع قرار، كخبراء، كمهتمين بصحة المرأة، حضوركم وتواجدكم جدا مهم لمناقشة هذه التحديات وهذه السياسات والخروج بتوصيات تخدم المرأة في المملكة العربية السعودية. فشكرا لكم ولحضوركم.
شكرا دكتورة فاطمة. أيها الحفل الكريم، الآن يسعدني أن أدعو صاحبة السمو الملكي الأميرة نورة بنت محمد العبد الله الفيصل لتلقي الكلمة نيابة عن صاحبة السمو الملكي الأميرة موضي رئيس مجلس إدارة جمعية رفيدة. تفضل.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيد المرسلين. والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى صحبه أجمعين، أصحاب المعالي والسيادة والسعادة والحضور الكريم، السلام عليكم ورحمة الله وبركاته. وبعد، أود أن أرحب بكم نيابة عن صاحبة السمو الملكي الأميرة موضي بنت خالد، والتي منعها ظرف طارئ أن تتواجد معنا اليوم، ولكن جميعنا نتقدم لكم بالشكر الجزيل على حضوركم ودعمكم الدائم لصحة المرأة وحقوقها الصحية. نتشرف في منتدى سياسات صحة المرأة هذا العام بالشراكة الاستراتيجية مع هيوستن ميثودست، ونتطلع معكم اليوم لمنتدى قيم وتوصيات داعمة لأفضل الممارسات الصحية والتي تتماشى مع رؤية مملكتنا الطموحة. شكرا لكم.
شكرا صاحبة السمو الملكية الأميرة نورة بنت محمد العبد الله الفيصل. الآن يسرني أن أدعو السيدة كاثي إيستر الرئيس والمدير التنفيذي لهيوستن ميثودست لخدمات الرعاية الصحية العالمية. Thank you, Your Royal Highness, for your words. And now, ladies and gentlemen, it's my honor to introduce Mrs. Kathy Easter, President and CEO of Houston Methodist Global Healthcare Services, who will give her address, please.
Your Royal Highnesses, Your Excellencies, our distinguished guests, ladies and gentlemen, Assalamu alaikum. It is with great pleasure that I stand among you today to take part in the 4th edition of the Rfida Health Advocacy Conference, an event that gathers all of the right people to discuss and advocate for women's health, a key aspect of women's empowerment and, importantly, equality. Our strategic partnership with Rfida and the Kingdom has been a testament to Houston Methodist's commitment to translate international healthcare standards into the Kingdom and into the region, to support the extraordinary transformational efforts in healthcare, and to support the efforts exerted by organizations such as Rfida to make sure that no one is left out, especially women. In addition to the programs and work mentioned by Princess Nora, Houston Methodist has always sought to blend its outstanding medical treatment with remarkable personal care. Our women's health services further this goal by making sure that women at every stage of life can count on receiving undivided attention and personalized treatment. Moreover, we realize the importance of the role that women can play in healthcare as practitioners and as recipients. Our joint efforts with strategic Saudi partners, such as the Saudi Ministry of Health, the Saudi Commission for Health Specialties, King Faisal Specialist Hospital and Research Center, the Ministry of Defense, and many others. We have seen more than 50 female Saudi healthcare leaders participate in Houston Methodist global leadership programs. The work is on the way. There's a lot to accomplish. I look forward to the outcome of this year's conference and to our growing partnership with Rfida and with the Kingdom. Shukran.
Ask you to remain on the stage. And شكرا لكلمتك. والآن يسرني أن أدعو صاحبة السمو الملكي الأميرة نورة بنت محمد العبد الله الفيصل لتكريم الشريك الاستراتيجي هيوستن ميثودست. تفضلي دكتورة فاطمة. كما تكرم أيضا هيوستن ميثودست جمعية رفيدة لصحة المرأة لهذه الجهود المبذولة. كما سيتم الآن تكريم الشركاء الاستراتيجيين لجمعية رفيدة في تقديم كل الخدمات والدعم اللازم لهذه الجمعية. ونبدأ التكريم ببنك الجزيرة الشريك الاستراتيجي لبرنامج تحكمي وبرنامج زهرت، ويتقدم باستلام الجائزة أو التكريم الدكتور فهد العليان. شركة بوينغ الشريك الاستراتيجي لبرنامج بدون خجل، وتتقدم باستلام الجائزة الدكتورة زينة الهجن. شركة MSD الشريك الاستراتيجي لبرنامج التثقيف الصحي، ويتقدم باستلام الهدية أو الجائزة الأستاذ عبد الله نبيل. مجموعة السلمان لدعمها اللامحدود لجمعية رفيدة لصحة المرأة، ويتقدم باستلام التكريم الأستاذ سلمان الجشي. نرسل لهم التكريم بعدين. شركة إيلاف، وذلك لدعمها لبرنامج رحلة أمومة وبرنامج الصحة الجنسية، وتتقدم باستلام التكريم الأستاذة بشرى العريفي، مؤسسة علامة طهارة للصحة النسائية. مركز الملك سلمان الاجتماعي، الشريك الاستراتيجي لرفيدة لصحة المرأة، وتتقدم باستلام التكريم الأستاذة أسماء الحربي. ويبقى المتبرعون هم الركيزة الأساسية لدعم تحقيق أهداف الجمعية، فشكرا لإيمانكم بمستقبل أكثر وعي وصحة. شكرا صاحبة السمو، شكرا دكتورة، شكرا لكم جميعا على حضوركم الباهي الذي زاد الملتقى جمالا وروعة، وشكرا لكل من ساهم في إخراج هذا الحفل بالصورة الرائعة. الآن أترك المنصة للأستاذة نجلاء الهديب لبدء البرنامج العلمي وباقي الفعاليات. وبالنسبة لي أتمنى لكم ملتقى مثمرا مفيدا لكم جميعا، وحتى نلتقي مجددا أترككم في أمان الله وحفظه، والسلام عليكم ورحمة الله وبركاته.
السلام عليكم. أسعد الله صباحكم بكل خير. حضورنا الكريم، نبدأ اليوم إن شاء الله أول جلساتنا الحوارية ترأسها الدكتورة لميا بنت عبد المحسن الإبراهيم، استشارية طب الأسرة والمجتمع. Would love to welcome Dr. Lamia Ibrahim, consultant family and community medicine, to lead our first session.
السلام عليكم حضورنا الكريم. Good morning everybody. صاحبة السمو الملكي الأميرة نورة بنت محمد بن عبد الله الفيصل، صاحبات وأصحاب السمو والمعالي والسعادة، حضورنا الكريم، السلام عليكم ورحمة الله وبركاته. أتشرف بترأس الجلسة الأولى، وأشكركم أيضا مقدمة لتخصيص يوم من يوم العطلة الأسبوعية لحضور هذا المنتدى ومشاركتنا مواضيع تخص صحة المرأة برعاية جمعية رفيدة لصحة المرأة وبالتعاون مع يوفر ميثودست. جلستنا الأولى تخص العافية والتعافي، يقدمها متخصصان متميزان. المتحدثة الأولى هي الدكتورة دانيا بنت حسين الجارودي. الدكتورة دانيا استشارية طب النساء والتوليد وعلاج العقم والجراحة الدقيقة، مستشارة معتمدة في طب نمط الحياة، وعملت سابقا كرئيس لقسم طب الإنجاب وعلاج العقم في مدينة الملك فهد الطبية، والآن تشغل منصب المدير التنفيذي لمركز الأبحاث في أيضا مدينة الملك فهد الطبية بالرياض، تابعة للتجمع الصحي الثاني. محاضرتها ستكون لتحقيق العدالة الصحية والاستخدام الأمثل للموارد وإنشاء سجل وطني لتقنية المساعدة على الإنجاب. دكتورة دانيا، أتمنى أنها تنورنا في المسرح. الله يعطيك العافية. المحاضرة الثانية حتكون مع الدكتور أحمد بن زهير الأيوبي بعنوان العافية قبل التعافي، أي هي نفس موضوع الملتقى. دكتور أحمد استشاري طب النساء والتوليد في مستشفى اليمامة التابع للتجمع الصحي الثاني،
وهو مؤسس مجموعة من المجموعات، عديد من المجموعات الخاصة بسياسات، الخاصة بالطب التكاملي، الخاصة أيضا بالاهتمام بتقديم المشورة الصحية وغيرها، ويعنى كثيرا بالولادات الخطرة ورعاية الأمومة الحرجة منذ 2008، وهو متخصص كذلك في الطب القانوني منذ عام 2000، وكذلك الطب التكاملي والعلاج بالصوم من عام 1995. دكتور أحمد، شرفنا في المسرح، الله يعطيك العافية. عليكم السلام. سنبدأ حاليا بالجلسة الأولى مع الدكتورة دانيا.
بسم الله الرحمن الرحيم. Thank you for the great invitation. Thank you for all. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Today my topic is going to be a bit different. It's a combination of both assisted reproductive technology and what we really need to do in terms of implications and policies and reducing morbidity and mortality. So my outline is going to be about what is ART, what is international data, importance of a registry, the purpose of a registry, safety data, and conclusions. So just a quick update on fertility treatments, if just a recall on ART. And ART is assisted reproductive technologies, and in most cases this leads to successful delivery of healthy singleton pregnancies. There are complications of pregnancy from ART treatments. We know that the infants conceived by fertility treatment, encompassing both IVF and other treatments. Closer? Okay. Such as ovulation induction, intrauterine insemination will lead to preterm deliveries and low birth weights, and multiple gestations. And we all know that multiple gestations have their own implications on different things. One study also suggested that IVF conception had a 1.5 times increase in preterm delivery, and specifically in 32 to 36 weeks of gestation. The risk of multiple pregnancy is also increased, and then in the US only 35% of all births were really from IVF and ART. I'm just going to go just give you a case that we sometimes face, and this is an example of a 31-year lady had IVF in our center, in another center, and developed ovarian hyperstimulation syndrome. She was admitted to the hospital for 2 weeks, delivered a preterm infant, and the baby stayed in the NICU for 4 weeks. So, such cases, makes us think, why did this happen? What has happened? What has, the implications of cost? So ART, as we mentioned, is a procedure, and it was initiated in the Kingdom in the 1980s, and we have currently now over 35 centers in the Kingdom supporting ART. And as we all know, the International Committee for Monitoring Assisted Reproductive Technology in the, international level has, so many data on what is happening in the center. And there was only one report from the Middle East and, few centers that has, collaborated with this and, had information in relation to ART registries. Programs such as ICMART and MEFS, which is the Middle East IVF Registry, have critical insights onto the progress, success, constraints, and risk of ART. For example, the association between ART and birth defects is equivocal, mainly due to sample size affecting statistical power. So why am I saying all this? Because only when a national registry is in place can a true understanding of the status of ART, which is the assisted reproductive technologies, in the Kingdom be acquired. And strategies for assuring state-of-art services are provided, developed, and research plans are customized to patient population. We really need to, look at our success rates, and we need to develop guidelines and recommendations, specifically if we have a registry in place. IVF, as we all know, started 30 years ago, and the first offspring was in the 1970s, and so many IVF, around the world has started developing. And just a reminder of assisted reproductive techniques, it includes something called in vitro fertilization, embryo transfer, intracytoplasmic sperm injection, and other treatments. So ART has been used in the US in the 1980s as well, and it is estimated to currently be responsible for more than 1% of births in that country. and this is also in the kingdom as well. Collection of national data was very important in the US and Canada in the 1980s and in 1990s. There's something, like a mandate by the CDC and the ICMAR that required by law that, registries has to be in place. The ICMAR is a registry and it is known worldwide, and it collects and analyzes data from national registries at a national and international level as well. ART procedures in the kingdom, as we have mentioned, there are many centers, and as we have mentioned in the MEFS, the Middle East Fertility Registry, in 2001 has started and collaborated with the ICMAR as well. So the importance of registry. Only when a national registry is in place can a true understanding of the status of ART in the kingdom be acquired. I feel there's an echo. For assuring the state-of-art ART services. So ART procedures, in the kingdom there are 26, 74%, centers that are private, and there are others that are governmental. So by definition, a registry is a database on patients who share a particular characteristics, and this is important. Why? To assess quality, care, monitor trends, and do research. So there are several well-known disease registries in Saudi Arabia, for example, the Saudi National Cancer Registry and National Diabetes. So the purpose of the registry is really to acquire data and make sure it is valid, comprehensible, and accurate. So when we start a registry, we're really looking at different populations, specifically those who are undergoing ART. We need to make sure that the definitions are consistent and the data is really valid. So, when we want to develop a data, we need to make sure that the resources are really allocated appropriately and there is a quality control on this data. So the ICMAR, I'm just going to give you an overlight, highlight on the ART data. In 2018, there were, data, because as we cannot take it, very recently, because we need to look at the live birth and the complications that happen after ART. So in 2018, there were over 600,000 ART cycles from 53 countries, and the single private center only from Saudi Arabia has really presented the data. As you can see here, in 2018, 79 countries contributed to that, and over 2,000 clinics. And the registry, as you can see, the number of ART cycles have been increasing. And if we compare it to 2006, you can see that it is six-fold increase from 2018 to 2006 to 2018, and in 2016 only over 100,000 ART cycles were recorded. Who are the ART stakeholders? Who is going to benefit really from an ART registry? It is the couples, the patients who are really being treated. They will look at information, they will benefit from the acquired treatments. Clinics, professionals, industries, regulators, allocators of resources, they will really look at this and they will understand why it is needed. So the outcomes usually include pregnancy rates, how many patients got pregnant from, after IVF, what is the multiple gestational rate, delivery rates, and the efficacy and the quality and cost and time, all will be recorded in this registry. Safety data is also important, and it will include, because it will, at a long term, will include medical, psychosocial, long-term and short-term effects in those. The safety data also is important, and we will make sure that, the data is clearly defined, the data is relevant, safety data is there, and data is not obtainable from other sources. So what is also needed in a registry? We will look at public versus private hospitals, academic, non-academic, large versus small hospitals, urban versus rural, types of services provided. The data in this summary, I'm not just going to go quickly over it. It will include different variables in the registry to include how many cycles, what are the number of oocytes, how many pregnancies has happened, how many multiple births, what were the complications, and so forth. Who will be using the data afterward for the registry? The patients, the infertility specialists, the scientists, the obstetricians, pediatricians, and of course policymakers. And it is important also to note that in a good registry has to, have a good quality data, and we will make sure that who is going to collect the data, who evaluates the baby, who, what evaluations will be there, how long the follow-up will be. So the registry process is also, has its own, inputs and has its own timing. So when this is in process, it will be very important for our patients and for our quality services. we will assure that the data is valid and quality is maintained. So this also rapport and trust. As we all know, some clinics are really reluctant to disclose their results because, there are maybe some issues, but we need to assure these clinics it is really for their own benefit and to improve the services and their outcomes. So that's why on this platform, I'm calling for a national registry at the level of the kingdom to make sure that, we initiate a national registry, which is important to make the understanding of unique features of ART and KSA and inform other clinics in their status and to, make sure that the quality of their ART services are maintained. So the Saudi ART registry will be a prospective registry collecting information from all cycles participating centers in the kingdom. And an important center, there should be a coordinating center that, has ART services and makes sure to overlook this ART registry. I want to cut the story short and, not to bore you with all the steps, but, we need, a data registry to include entering each individual patient in the ART cycle, verifying the data accuracy, submitting it to a coordinating center, and making sure that all data is received and the ethical requirements are there. This is an example that I was proposing. This is the Saudi ART registry survey. We're looking forward into making a survey on a national level, making sure how many ART centers are there. Is it a governmental hospital? Is it a private hospital? What types of services? How many cycles are they providing? Are they accredited internationally or nationally or so forth? And what types of services are they providing? And this is an example of what are the lab services they are also providing to make sure this is all there. We're looking also to make it automated, and these are all the requirements by year, by month, and what is the important variables that should be there. What are the regions that are involved? Is it in the east? Is it in the west? Is it in the center? And in conclusion, we propose to establish a voluntary nationwide ART registry in Saudi Arabia, collecting comprehensive data on all procedures, and specifically to benchmark, analyze the trends that are happening in the kingdom, determining the status in relation to the Middle East and the rest of the world, to elaborate recommendations to improve practices on evidence, and to develop a culture of information sharing, and to develop practice guidelines. And this is an important project that we expect to enroll different centers, and the acquired data should be prospectively included from 2024, 2025, and we look at, the anticipated success from different centers. And additionally, we are looking at, the most important thing and the long-term outcome of cost-effective reduction in NICU admissions that exerts a huge burden on all NICU centers in the kingdom. And I have really wrote a paper in 2016, and I was calling for a national ART registry, and because it is very important to have this data. So the benefits, the regulators will have information needed to make evidence-based ethical decisions and legal regulations. The allocators of resources will also provide benefits to the public at large. And we also anticipate the information obtained is very important for information and valuable publication summarizing the ART. We plan to participate also in ICMART and MEFS registries, allowing comparison between Saudi Arabia and other regions in the world. Finally, we expect this venture really to provide evidence indeed for information sharing and beneficial to ART in Saudi Arabia. We envision that the Ministry of Health will support and make sure that the Kingdom and the Saudi ART registry is official and a mandated registry at the level of the nation. Thank you so much. Thank you for your attention.
شكرا دكتورة دانية على هذه المحاضرة القيمة وكثير فيها معلومات وأسئلة، بس حنترك الأسئلة إن شاء الله بعد نهاية الجلسة الثانية مع الدكتور أحمد الأيوبي. الجلسة بتكون أكثر حاليا وقائية، العافية قبل التعافي. أهلا دكتور.
السلام عليكم ورحمة الله. We've been always in our life focusing on disease, and this is basically how we've been trained, how we've been tackling things. We always look into diseased people. And the question is, how about we look into the well? Because basically, majority of the society are well, and we want them to be prevented into becoming sick people. So maybe it's time that we go and focus and go broad and take the zoom, we take the zoom out so we can see the others and try to make them as well as possible. The question is it actually the same as wellness versus health? When we say health and wellness, are they the same? Wellness is a modern word with ancient roots, that the key tenets into wellness, both preventive and holistic, can be tracked back to the old ancient civilizations, whether at the East or at the West. The 19th century in Europe and the United States, a variety of intellectual medical movements developed parallel with the conventional medicine, with their focus on holistic and natural approaches, self-healing, preventive care. These movements have provided from foundations and wellness today. Wellness focused on holistic modalities and have gained more visibility in the 1960s and 70s by tremendous actual work done by thinkers and physicians, and this basically such as Halbert Dunn, Jack Travis, Don Ardell, Bill Helter, and others. And these have evolved, proliferated, and gone mainstream. They have informed the healthy living, the self-help, and again the self-care, fitness, nutrition, etc., etc. So we are moving into new dimensions and new aspects of what we really mean by wellness. Now, being healthy is disease-free. The question is, are you really well? Is there something going on in the prodrome? Is there something cooking on that actually we do not really pick it up yet? Your vitals are fine, your usual screening, basic screening is fine, but the question is there something going on? Now, there are two important aspects of the definition why wellness is different than health. The first one, wellness is not just a passive, static state, but rather an active pursuit that is associated with interactions, choices, actions, work, optimal state of health and well-being. The second thing is, it is not just basically focusing on the physical part, it's rather a holistic approach to other aspects and dimensions. Wellness is often confused with terms such as health, well-being, happiness. While there are common elements among them, they are distinguished by the static state. Wellness is not static. Again, rather, wellness is associated with an active process where you make choices, where you go around and interact with what's happening around you. And basically, you are always in a continuous choices. The Global Wellness Institute has defined the wellness as the active pursuit of activities, choices, lifestyle that lead to state of holistic health. Wellness is a multidimensional. It's not just only one aspect. It's not only just the person. Wellness is about more than just physical health. It's basically 6 dimensions, and sometimes it goes up to 9 and 12 dimensions. Physical, which is nourishing healthy body through exercise, nutrition, etc. Mental, which is engaging the world through learning, problem solving, etc. Emotional, being accepting, expressing our feelings and understandings, and basically to others. Spiritual, it's not faith, it's rather meaning the higher purpose in human, whether actually where you look at and when you interact with the universe, and connecting the engaging others in social life, and again environmental, and this is basically interacting with all what goes around you, and the environment for us that goes just in the room, and then it goes as far as you go around. Now, if we actually see the comparison that goes between the two conventional paradigms we have, which is the thing which we use basically, the medical paradigm, feel better, treat and cure, corrective, episodic, clinical responsibility, and compartmentalized. It's like basically you go from one specialty to another, from one subspecialty to another, and so on. While wellness paradigm is much wider and more really scarce when you go around, it's basically to thrive, it's to maintain and improve that health, it's preventive, holistic, individualized responsibility, and integrated life. Again, wellness versus well-being and happiness. Let's take another example where actually we look at it into like decision makers and others. It relates to intention, actions, and activities versus perception of a state of being. The other one has a prominent physical dimension, while actually prominent mental, emotional dimension. Consumers associated in healthy lifestyle choices and market offerings citizens associated with feelings and satisfactions, and so on. So the comparison between the two is very clear. We're going actually more broader. We're going actually more into being not just imprisoned by one shape or modality. Now, is this related to our vision, our healthcare transformation in Saudi Arabia? The answer is absolutely yes. Now, actually, Ministry of Health is moving from being the Ministry of Sick or the Ministry of those who need help into the Ministry of spreading wellness with all other community partners, rather than just actually the sick people. It's like basically outside healthcare premises, rather than hospitals and primary care centers. The healthcare, 6 major pathways, one of them is basically to keep well, and this is basically involving everyone with the healthcare transformation, and which will be more visible by 2030. Again, let's go and see wellness versus health. Number of beneficiaries versus number of beds. We are tied to the number of beds, and we're tied to how many actually operations we do and how many medications we prescribe or tests and so on. So what are the secrets of wellness? Eat less, move more, sleep well, breathe deep, control your stress, stay around with mindfulness. All this with mindfulness. It's basically, there's no secrets about what type of nutritional system you'll use. I'll use keto, that was carnivore, vegan, high vegan, whatever. It's basically just the general principles of just actually living there and being aware and interact all together. What's happening in our current medicine? Non-communicable chronic diseases, they're actually sky high. The pain and disability becoming more and more. Constant increase in cost. The quality of life is going down. سلوا الله العفو والعافية فإن أحدا لم يعطى بعد اليقين خيرا من العافية. اللهم إني نسألك العفو والعافية. Thank you so much.
العفو والعافية هي كانت ختام جلسة الثانية، فمش عارفة انتوا حابين نتكلم بايلينجوال ولا it's okay when we speak Arabic? It's okay? Okay. لأن هنا التوصيات حتى في المملكة إنه نتكلم باللغة العربية في الملتقيات، فحابين توجهوا أي سؤال للدكتورة دانيا، الدكتور أحمد. تفضل يعطيك العافية. في مايك؟ فضلا لو تعرف باسمك وثم السؤال. الله يسلمك. في جاي مايك الحين. فضلا الاسم والصفة والسؤال موجه لمين؟ الله يسلمك.
بسم الله الرحمن الرحيم. My name is Hassan Masloum. I'm a physician by trade and a member of the Shura Council. My comment, first of all, I strongly support Dr. Dania's call to launch a national registry. But it would be very remiss if I didn't start by thanking Her Royal Highness Princess Modi bint Khalid for her continued leadership as the president of the board of directors of Rafida Women's Health. This leadership style, which is grounded in compassion and kindness and humanity, is inspiring to all of us, and we admire her so much for that. Although she is physically not here, but her presence is palpable all around. I'd just like to make a very small comment about the National Registry. It's non-disputable that the acceptance of and the usage of the assisted reproductive technology is dependent on a complexity of various aspects, namely the social, the financial, the cultural, and religious. And they are virtually impossible to disentangle in our society. So we need to explore the implications of these factors in all domains of the assisted reproductive technology, beyond the number of treatment cycles. And through that exploration, we need to disclose and uncover if there are a problem with access, because we need to establish equity to access.
Excellent.
Yeah, and inequity to access, there are, stemming from lack of affordability or restriction, severe restriction in age limit. It has its own practical consequences. One of them is the increase in migration of patients abroad and out of the border, and that brings a whole gamut of problems. The first problem, you're going to expose those patients to an environment that is less clinically controlled. The second one, you will have lack of tracking of those reproductive cells and the lack of outcome on those individuals. And third, it will hamper the national biovigilance in here. So we need to have, if we're going to establish this registry, the national registry, we need to have it comprehensive to capture those outliers case by case and bring them back to the data collection agency. I have a lot of questions about, this topic, because we need to have also equity of the access to the public financial assistance, which is an issue. In your lecture, you said 76% are private sector, and just a minority are in the public domain. So there's a lot, but in conclusion, I'd like just to reemphasize my comment to you that I strongly support your and advocate for a national registry. It's time, and it's overdue actually, because I know of registries in Europe that have been there for more than 30 years. Yeah. Thank you very much.
Thank you. Thank you for your comment. I actually echo what you're really worried about, because, access to care is very essential and important. And that's why I was thinking, when we establish a national registry, as we all know, sometimes, patients, there's a long waiting list for, ART services. And some patients are very fortunate to have, different files in different governmental hospitals, while others are really waiting to get access to care. And, that's why I said a national registry. Maybe we identify the patients with their national ID number, and then we can track what you're saying, every aspect of their entry into the service. Sometimes, as you know, they would open a file in our institute, in another institute, and another, and there's no way to know how many services have they really got, and the others are waiting a very long time to get this service, and the other implications that you were mentioning. Thank you. I would really like this to happen, inshallah. Thank you.
شكرا دكتورة دانيا. في حد حاب يسأل سؤال ثاني؟ أيوة دكتورة مها. المايك للدكتورة مها. الصف الثاني.
Dr. Mahal Munif, Professor of Pediatric Infectious Disease and Epidemiology. First of all, I would really like to thank Rfida Society for putting this forum every year on women health. And my question is to Dr. Ahmed is, when we talk about, illness versus preventive medicine versus wellness, and in medical school, we really focus on diseases and illnesses, and we touch a little bit on prevention medicine. But I think the education and the curriculum on wellness is really lacking in medical school. So I would really like you to touch on this point on how we can go forward on really focusing on prevention medicine, wellness, and well-being in medical school rather than focusing on diseases and illnesses.
أتفق معاكي تماما دكتور يعطيك العافية. فعلا احنا سميناها الميمات الأربع. تبدأ هذه القصة دائما من المنزل، ثم بعد ذلك المدرسة، فالمسجد، فالميديا. يعني هذا بيسك، هذا اللي حيصير. أنا بالنسبة لي مستحيل أتكلم عن العافية وأنا عم أتكلم عن شيء أصلا يخالف الواقع تماما، خاصة نعومة الأظافر. نتكلم إحنا على من يحبو، ونتكلم على الناس الصغار. تستغرب أنت كمية المستحضرات اللي هي أصلا معتمدة وتباع في الأسواق للأطفال اللي يعطى منها على أنها ماركات مشهورة وعالمية ومعروفة، كمية السكر اللي فيها والأشياء الثانية. بعد ذلك نستغرب ليش هذا الطفل تغيرت مقاييس الشهية عنده أو الطعام. ثم نتكلم عن التسوس في الأسنان، تسوس في الأسنان في مدارسنا 9 من 10 عندهم تسوس أسنان وهكذا. فأنا أتفق معاكي. العافية في فترة من الفترات كانت بالنسبة لي أنه حاجة يعني كذا عافية وخلاص، بينما هي أساس كل شيء. دائما تبدأ من المنزل. كيف لي أني أطلع أولاد فيهم عافية إذا كانوا الأهل هم نفسهم لا يمارسوا العافية؟ لا تشرب بيبسي ما هو كويس عشانك، طيب وليش أنت تشرب؟ وهكذا. كيف إنه والله الطعام والغذاء والحركة والسهر والنوم، الأشياء هذه كلها بصورة عامة تؤثر على حياتنا. حياتنا أصبحت الآن أغلب الناس يعني مرتبطة بالأجهزة كله، حتى أحيانا تجلسي في جلسة الخمسة أو الستة أو السبعة فوبينج everybody is there basically ماسك جهاز وشغال فيه. فأنا أتفق معك، هي عودة إلى الوراء، خطوة إلى الوراء، لكنها أعتقد في غاية الأهمية لأنها مستدامة. كمية المال اللي حتصرفه حيكون أقل بكثير، ثم أنت تعيد مرة ثانية إلى الجسم وضعه. يعني إحنا بنتكلم دائما مناحي الطب دائما هي 5 ما لها سادس: preventive, revertive, regenerative, fixative, whatever if we're doing surgeries, وأخيرا palliative. أول 3 I think is very important نحن to focus on. وأعتقد إن شاء الله 2030 وتحولنا في القطاع الصحي is moving toward this. إشراك الجميع في الموضوع. الفعاليات الصحية ما هي أسبوع الشجرة وأسبوع الكذا وخلاص، هي basically حاجة مستمرة في مدارسنا ودائما موجودة معنا. المدرس في النهاية هو كوتش، الأب والأم هم كوتشز and so on. كثير من الأحيان إحنا المريض يوم يأتيك هو عارف معلومة، ما هي يعني we don't need health education، هو عارف المعلومة، عارف كلها أشياء ضارة إلى آخره. يحتاج إلى motivation، كيف يبدأ، كيف ينتقل إلى المرحلة اللي بعدها. مشكلتنا دائما يعني نملي عليه، عليك أن يجب أن. طيب سؤالي يعني أنا عارف الكلام هذا، كيف أبدأ؟ يمكن أحتاج أحد يكون معايا. I need a coach rather than someone يعني بيعطيني شو اسمه عبارة عن pamphlet أو إنه والله site and go there. I need someone to go with me step by step.
نوجه سؤال ثاني بس إلى الدكتورة دانيا. اسمحوا لي برضه أنا معكم زميلتكم. لما تكلمتوا دكتورة دانيا كنا يعني موضوع أصلا هو عنوانه العدالة equity and equality. لما نقول إن نخصص registry for the women أو women for a specific part اللي هي موضوع الريبرودكتيف إلى الفيرتيليتي، وهذا الموضوع احنا عندنا مثلا حتى لما نتكلم في المملكة يرتبط بالعلاقة الزوجية، فمتى ما انتهت العلاقة الزوجية فإذا الموضوع هذا أصلا هو طبيعي حيتوقف. هل تشوفي كيف نقدر أو إحنا نتفادى موضوع الإكواليتي والريسورسز نفسها ككوست إفكتيفنس؟ ما هي الفائدة التي سنجنيها أو ستجنيها النظام الصحي من تخصيص منصة أو ريجستري خاص بالصحة الإنجابية إلى المرأة أو للعقم ولأمر محدود لربما ينتهي؟ كيف حيستفيد منه أصحاب القرار؟
Let me answer in English because like the registry in my mind is in English and set in English, but like I'm thinking is now we're talking about equity and equality. Like as I mentioned earlier, if if we identify these patients by their national ID number, like for now what is happening, like let's say in our governmental institute we're giving the patients, let's say 3 cycles of IVF. After that, like it depends if she got pregnant or not, and then we will assess and see if she's eligible for another IVF treatment, let's say. But I'm telling you, this same patient might be having another file open in another governmental institute and she takes another 3 while the others are still waiting. So developing a registry will, like at a national level, like covered by insurance, she will be allowed, let's say 3 to 4, 5 IVF cycles. And like this will be equal to other patients that are on the waiting list receiving 5 or 4 IVF cycles. It will not be this patient receiving 6 cycles because she has access to different hospitals, and one patient has only access to one institute and she's on the waiting list. That's my point. Identifying the patient by a national identifier and making sure what treatment is she really receiving and is it fair and is she abiding by the guidelines or not. But now, if they have open access to care and it depends on, let's say the efforts of her husband opening a file here and there, this will not be happening if there's a registry and set by a policy and a guideline and what is the number of IVF cycles that she is really eligible for.
شكرا دكتورة. Thank you. سؤال مايك لو تكرمتوا على الصف الثاني. في عندنا سؤالين برضو. أيوة السؤال برضو الدكتورة منى حتسأل، فعندنا سؤال. هي.
Assalamu alaikum. Good morning. My question to Dr. Ahmed. This is Dr. Yasser Al-Atiq. I'm a consultant radiologist. I was luckily part of a team who were designing the model of care in 2017 and 18, in addition to the private sector participation in the VRO. And now I moved to the private sector. My mobilization to private sector is related to consolidate and solidify implementation of the concept of the prevention medicine, in addition to prediction medicine, if we call it this way. When it comes to the prevention, I think we were honored that Dr. Lamia visited our center, looking into the upstream prevention, which I think it's a very important neglected area of practice. When we say upstream prevention, means early detection of the diseases based on the genes mapping, based on the, in addition to the patient behavior, living the lifestyle, and the lifestyle, how does it affect our future health? And what is in the healthcare system may support conjoining those three aspects together. So sometimes the people, they have the genes can lead them, for example, to a breast cancer, or can lead them to a colonic cancer or to prostate cancer. But despite having this type of genes, the health system is not supporting to prevent or to push back such kind of diseases if it's going to happen in the coming future or the soon future. Similarly to the Alzheimer's disease that we know now, it's almost gene and behavior and lifestyle related diseases. So where's the health system that can help to push back through implementation of the prediction? Also technology may help nowadays through the AI. So the question is, how can we really, rather than going into the very basic type of prevention, like let's eat less or walk together, and going into the upstream prevention and make it available for the public?
I definitely agree with you.
معلش بس دكتور احمد حناخذ سؤال دكتوره منى على اساس لانه حيكون اخر سؤال. ايوه بس وبعدها تكمل الاجابه. دكتوره منى في.
السلام عليكم ورحمة الله وبركاته. بداية أتقدم بالشكر الجزيل لصاحبة السمو الملكة الأميرة موضي بنت خالد، ولسمو الأميرة نورة بنت محمد، والزميلة الأخت الفاضلة الدكتورة فاطمة الهملان على تنظيم والاهتمام بجمعية رفيدة بصحة المرأة. معكم أنا الدكتورة منى المشيط، عضو مجلس الشورى وبروفيسور، أنا أستاذ بطب النساء والولادة. عملنا كثير على موضوع صحة المرأة في مجلس الشورى. And women's health was the priority for us and to be implemented in the health system in Saudi Arabia. Alhamdulillah, it's going more than what we are expecting. حاليا نحتاج التوعية الصحية. يعني أشكر الدكتور أحمد والدكتورة دانيا. القضية قضية الملف الصحي الموحد or the unified medical file. We asked for this one several times. إنه it will be very informative for registry, not only for ART. It's one single issue, but there are too many things for our society, for this health file, and to be for each patient. So whatever she go to the military hospital or because each patient, she's eligible like in the military hospital, also she is eligible in Ministry of Health, and also some of them the same patients with the insurance, medical insurance from her work or from work of any one of her family. To control ART also in the private clinic. I'm not worried about the government sector, but the private يحتاج تنظيم وتنسيق بشكل كبير جدا، حتى في الأحقية من ناحية العلاج، لأنه بعض المراكز يتم تحويلهم من بعض الجهات الحكومية. فهل من السؤال الدكتورة دانيا، هل للقطاع الخاص أو البرايفت سيكتور للآي في اف سنترز أي دور أو سعي لتنظيمه من ناحية حتى الأحقية؟ صحيح إنه بعضهم from as a private but still there are some patients which they can have the priority than others. وللدكتور أحمد من ناحية العافية قبل التعافي، توعية المجتمع، ماذا ترى دور وزارة الصحة في زيادة عدد أو زيادة الفعاليات اللي تثقف المجتمع في هذا الموضوع؟ شكرا جزيلا.
الله يعطيكم العافية. دكتور أحمد، بس إجابة الدكتور ياسر ومن ثم إجابة الدكتورة منى.
Sure. طبعا I definitely agree with you, doctor. The simple saying of wellness, إنه move and style. Lifestyle change is really important. You know, when somebody comes and he's overweight, obese, smoker, etc., and so on, where to start? Start by modifying what you have and so on. However, we have actually three categories of people in the community: those who are diseased, the general public, and those who are not showing any disease so far, which could be one of two: either someone who has a genetic predisposition that did not show into disease yet, or they are still in a prodrome, which means no symptoms yet, they did not show a symptom. Can I consider these are the same? They are different baskets, definitely, and that's why the advice will be not the same. Again, what about epigenetics? Again, what about many things? For example, now when we say coffee, is it good or bad? We have found that your genes would determine if this coffee will be making you good or bad according to your genes. And again, depression. And again, actually, this is related to lifestyle exercise. Some people, when they do the exercise, it might be leading to wasting of muscles rather than gaining. Why? It's again genes. It's a huge work that have been done in the last 10 years on genes and using of genes in the well-being rather than the diagnostic part, which is very important. Those with genetic predisposition, say BRCA1 and so, what is the advice? What shall they do? Can we modify genes? Can we modify the appearance of a disease with certain modifications? The answer is yes. And that's why wellness is beyond just the general, and here we're coming to personalized medicine. I'm giving you a prescription for you by your name, by your age, not actually for everyone. Take vitamins from A to Z. Who knows what are the missing parts in my body? Not like someone else and so on. That's why please take what you need, not just actually one product that fits all. So that's actually, I definitely agree. Prevention is the general umbrella. However, under this prevention goes a lot of domains. Regarding your question, Doctora, again, two things, two concepts. Number one, we usually instruct the person, وقف, لا تعمل, أحسن توقف, خطر عليك, إلى آخره. It's really not helping. It's not helping. Somebody comes to you, he or she will tell you, I've been trying to quit smoking, I've been trying to exercise, I've been. So is it really a matter of education? They are educated. They know it's wrong. So how can they move into the next step? Here, this is the issue. And that's why when we say from education to motivation, they need people. Now, to be a coach, not everyone can be a coach. Someone actually has the talent, has the knowledge, and the dedication. And that's why actually I think it matters and it differs from one person to another. Just actually to tell someone, do this, everybody knows that. Even kids now, they know at school that this is not good for you and good for you, however they're doing it. We need to allow certain escapes, or they call them cheat meals and so on, in order to achieve the best result we can. And again, people response varies from one age to another, and gender to another, and a country to another, and so on. The kingdom, for example, see what happened in the last 10 years. Female schools, they were banned from sporting. It was not allowed. But now actually you see people everywhere. You see even people going in street. You see fitness clubs. I remember one time there were one or two in Riyadh. They were very expensive so far. Now in every area you see tens of them. So you can see the transformation, the change that is happening. That's why it is not the job of Ministry of Health. And probably we've been lacking the effect because it was mainly concerned about MOH. Now everybody is involved.
دكتورة دانيا.
Yeah, thank you, Dr. Amuna. Thank you for the comment. You know, like, I think it's everybody's dream to have a unified medical file for the patients, as you mentioned, you know, like, because sometimes it really breaks my heart. It's, you know, like, whose fault is it? Is it the patient's fault? Is it the physician's fault? You know, like, because sometimes the patients come and insist they want IVF, and sometimes we really see patients undergoing maybe 12 cycles of IVF from the private, and then disasters are really happening, and then she ages, and you know, like at the age of 42, 43, 45, and who's there to tell them, you know, please stop, you know, like, because the patients are really, you know, like, suffering, you know, like, they're taking these medications, sometimes they have depression, sometimes they're, you know, like, puffed up, or, you know, like, they're increasing in weight. It just breaks your heart. Who is there to tell them stop? Is it us? Is it the rules? Is it the policies? Is it the guidelines? The patient is insisting that she wants IVF, and no one is there to tell her, you know, like, you know, like, you're harming yourself. As Dr. Ahmed mentioned, you know, like, some people do not know how to get themselves out of a problem, whether it is the physician or the patient. And I would like to emphasize on Dr. Ahmed's point, there is something called lifestyle medicine, and I really didn't know it until the 2021. And it's very important because it has different aspects in, you know, like, the wellness and our well-being. You know, like, diabetic patients can really be treated just by proper diet and walking. I tried it on my dad and it really worked. I didn't believe it. You know, like, simple things really matter. That's why we're healed, you know, like, we're patients advocate, we're physicians advocate, we're, you know, like, to put a rule to help people, you know, like, strive. I'm not sure if I really answered your question, but, you know, like, a unified file, registries, looking at different short-term and long-term outcomes, psychological aspects of it, financial impact on the government and on the patients themselves. You know, like, a registry at least will capture some of, you know, like, so many other variables.
Which is coming, Victoria, by the way, the medical file is already coming. It's just a matter probably of this year or next year. It's happening now. By Sahati, if you go in, the fees now is another platform. I think by probably the end of this year, we are going to be connected to everywhere. Private, governmental, non-governmental, everybody is going to be there. And as you mentioned, this is very important to know where we're standing. What are the common diseases? It's a huge bank of data that we can use for everything, for like future. We need to increase the life expectancy of people, yes, but we need them to be independent and well. But to increase the number of those who are disabled or, you know, with chronic disease, I think it's a problem.
Okay, اضغطوا علي كثير. It's 10:10, so now we have to stop. Thank you, Dr. Dania, Dr. Ahmed, for this valuable presentation. وشكرا لجميع الحضور. Thank you for all of you for listening. I'm sorry that I can't take all the questions. But Dr. Dania and Dr. Ahmed are here. You can question them directly, and thank you again.
Thank you, Dr. Lemia. Thank you, Dr. Ahmed, Dr. Dalia. We'll start our second session. Will be led by Professor Maha bint Abdullah Al-Mnif. أهلا وسهلا دكتورة Maha, Consultant Pediatric Infection Control.
صاحبة السمو الأميرة نورة بنت محمد العبد الله الفيصل، أصحاب المعالي والسعادة، الأخوة والأخوات، أهلا بكم في الجلسة الثانية of this prestigious Women Health Forum. Today we have two great speakers who will take us on a journey of women health and wellness, from adolescence to mature life to menopause stages of women health. Our first speaker, I would like to invite them into the podium here. Our first speaker is Dr. Namsha Al-Hajri. Namsha is a consultant in obstetric and gynecology. She had more than 12 years of experience in the field of mature women health, menopause, and aesthetic gynecology. Dr. Al-Hajri finished her Saudi certificate in obstetric and gynecology and attended a clinical fellowship program in Mount Sinai Hospital in University of Toronto and returned back to Saudi Arabia to work as a consultant in obstetric and gynae in King Abdullah bin Abdulaziz University Hospital in the Princess Noura University. She also works as a consultant in different private hospitals. Please help me to welcome Dr. Namsha Al-Hajri. Our second speaker is Professor Fadia Al-Buhayran. She's an adjunct professor of pediatric and adolescent medicine in Al Faisal University in Riyadh. She's currently working as a senior advisor at the Health Sector Transformation Program, which is one of the 2030 Vision program. Professor Al-Buhayran obtained her board certification in pediatric and adolescent medicine from University of Toronto and Sick Kids Hospital. She had a master's degree in public health from Johns Hopkins University, and she had a PhD from Maastricht University. She's a pioneer in the field of adolescent medicine, youth health in Saudi Arabia and in the MENA region, and she is a recipient of the 2020 Society of Adolescent Health and Medicine Award for her achievement in the field. I cannot really stop here and not mentioning her really a landmark study, Jiluna, on adolescent health, which is the largest in the MENA region and in Saudi Arabia. Please help me to welcome Professor Fadia Al-Buhayran to the field. So we will start, each speaker will have 15 minutes to present the issue on women health. Dr. Namsha will tell us about, mature health and menopause in women health. Dr. Namsha.
Assalamu alaikum wa rahmatullah. Good morning, everybody. Thank you for this opportunity. Thank you for allowing me to speak or talk on behalf of women in their mature level or at their mature age. So I'll start with some definition that will allow everybody to understand about what age group I'm talking about. Menopause marked the time of menstrual cycle cessation. So we diagnosed women as menopause when they complete 12 months with no period. Perimenopause is the area around menopause, means the women in their 40s and 50s, whether premenopausal or postmenopausal. So women spend third of their life in menopause and perimenopause, third of their life in childhood and adolescence, third of their life in reproductive age, and the third in menopause. Fortunate enough, we have all the facilities, all the setting. We have complete hospitals for pediatric, for adolescents, for women during the reproductive age. We have full services for all these age groups. Unfortunately, the women in menopause or at menopause, or the mature women, which is like everybody, our mothers, like wives, all of us, like after we reach our great ages, we are at full capacity, we are certified with everything, we can give more at this age. We don't have the full support, or we don't know to whom we can go. So we keep going to internal medicine, gynecologist, to orthopedic, rheumatology. We need a service, or we need the service that help us, or one place that help us with all the services, like one-stop shop. According to the statistics of Saudi Arabia 2017, over 5 million women are of menopausal age in KSA. And according to the Vision 2030, the expected age will be prolonged for more than 75 years and older. So the graying of Saudi Arabia over the next 25 years will present special challenges for gynecologists faced with unique needs for this age group of women. The specific problems of perimenopause, women experiencing the ramification of fluctuation level of estrogen are very different from the older female population who are troubled with the disease of aging and pelvic floor issues. So the health care provider must work to establish a more specialized clinic to enhance the health of women in this age and to reduce the comorbidities and the cost related to it. So, symptoms of perimenopause are similar and can include all these: hot flushes, night sweat, insomnia, poor sleep, palpitation, cognitive symptoms, brain fog, forgetfulness, and poor concentration. So usually women at menopause are teachers, are CEOs in companies. They teach in universities. A lot of doctors carrying PhD or whatever, or lecturing people, they come to me, or lecturing women, they come to me saying, I was flushing during my lecture or during my meeting. I couldn't complete. I had palpitation. Everybody in the meeting or in the committee know that I was flushing. I lost my idea. I can't control my speech. I don't want this to happen to me. Psychological symptoms like anxiety, feeling low, irritability, mood swing, lethargy and lack of energy, loss of interest in activities, tearfulness, muscle or joint pain, vaginal dryness, painful sex, reduced libido, urinary frequency, and incontinence. So I'll give you like 3 case scenario that I face. Like 55 years old, para 4+0. She said, come to the clinic, holding a fan. I can't take it anymore. I can't work. I can't function. I'm not sleeping. I have anxiety. I can't do my full duties with my kids or in my work. Some of them come with history of lack of energy. I can't take it anymore. I can't continue my work. What should I do? Or how can you help me? Unfortunately, after the WHI study, which is, I think most of us know about it, Women Health Initiative, everybody was afraid or refrained from using hormone replacement therapy. It's not that much available in the market. Most of the physicians with their primary health care provider or primary health care or even gynecologists, they even advised against HRT. So it's not available in the market. When they come to my clinic, I advise them for something that is either unavailable in the market, or if it is available, like the old HRT. The new one is not yet registered, it's not yet in the market, because most of us know if it is here, nobody will use it. Everybody is afraid from HRT. So even if she come to my clinic, I can't prescribe her anything. I can't help her. It's not available. Or I'll tell her, go somewhere else to bring this medication and this medication. Or unfortunately, and when they ask me, can I request it, or can I take it online? No, it's controlled medication. You shouldn't have it unless by prescription. So from this platform, whomever in authority, I need them to help us to open menopausal clinic everywhere to help us to bring the hormone replacement therapy that help in managing these symptoms and not let women to suffer or to have better quality of life. So, the complex menopause. Our to-do list is endless, but key goals include getting as much information or have this clinic to get as much information for menopause, to have data registry, to know menopausal or Saudi population menopausal. What more symptoms do they have? Usually, or our statistics about menopause and what is, or the other some menopausal symptoms is from other population. So we need menopause clinic to have our own registry, to have our own data, and because we know every menopause or every woman pass through menopause or have their own menopause experience, and there is no solution that fits all. There is no prescription for all. So we need all women to have their own we need to help all women with their own symptoms. So developing standards of practice for our own menopause specialists when it comes to prescribing HRT for patients with comorbidities, engaging with other services around the kingdom of keep practices consistent, and inviting colleagues in other hospital specialties to connect with us and help us in better service all of our patients. Doing some basic research on all of the above so we can get a sense of what might be needed as we go forward. To open doors and enroll patients, we hope to expand our referral criteria to include patients without comorbidities and who are struggling to find symptoms relief in spite of good support. So there also, like in this clinic or in menopause clinic, there will be training opportunities. In our board curriculum, we never pass by or pass through menopause rotation. It's not there in our curriculum. So having this clinic will help in the training of our physician. The vast majority of gynecologists didn't have exposure to comprehensive mature women health and menopause care as part of their traditional training, residency training program. So our clinic will help in that. Will present a wonderful opportunity for training resident and patient-centered, evidence-based mature women health care, setting aside some didactic time during the clinic session will ensure time to focus on training. These are some of the services that can be provided in menopause clinic. Well woman exam, values clarification for providers of mature women health care, mature women-centered contraception counseling, hormone replacement therapy options, sexual dysfunction, vulvar disease research opportunity. Thank you.
Thank you, Dr. Al-Hajri, for this very impressive lecture. And I would really thank you for your enthusiasm in creating a menopausal clinic. And I think I'll follow the steps of the previous session, that we would really leave the questions until the end. Now I think Dr. Fadia will take us into adolescent health in Saudi Arabia and internationally.
Can we project the slides? It's not projecting.
بسم الله الرحمن الرحيم. صاحبة السمو الملكي، أصحاب المعالي وأصحاب السعادة، السلام عليكم ورحمة الله تعالى وبركاته. Thank you, Dr. Maha, and thank you very much to Rfida Women's Organization for this wonderful opportunity. Really, really very important that you have brought all of the relevant stakeholders together. So thank you very much. I will be spending the next 10 to 15 minutes talking about adolescence. And this really is an area that is very, very often neglected. We speak about children, we speak about adult women and elderly women, but the topic of adolescence and young girls is very much missed quite often. I'm going to start by this statement, and will not explain it now. You will realize what it means by the end of this talk, and we'll touch base on it at the very end. Investing in adolescence reaps a triple dividend. Just think about that for a moment, and I'm sure more thoughts will come to you as we go on. So when I mention adolescence, I'm referring to individuals between the ages of 10 and 19 years. This is the global definition. We are a very youthful population. 15% of our kingdom's population are individuals between the ages of 10 and 19. So again, though such a significant proportion of our population, very often neglected and missed. Adolescence is a time of opportunity. So oftentimes, and when I first began my career in adolescent medicine, more than 17 years ago, people would question me. They would say, Fadia, why do you want this headache? There's other things that you can deal with. Why bother? And it's because the reason that people would say this, and oftentimes they continue to say this, is because they think of adolescence as a problematic time, as problematic individuals. On the contrary, it's an absolutely wonderful time, amazing young individuals, a time of opportunity. As a pediatrician and as a professional, I obviously work with people across the age spectrum, from birth until the very elderly. But by far, working with young adolescents, boys and girls, is by far the funnest and most enjoyable and really most rewarding to me as a professional as well as a mother. A time of opportunity because so much development happens. It's the physical development is very obvious. We all know what happens physically, the growth and puberty and whatnot. But there is significant brain and cognitive development. And that brain development actually does continue until the mid-20s. So it's not even ending at 19 years of age. It's a time of identity formation, a time of developing, certain values and interests, exploration of interest. And again, often people think about the exploration of interest being exploring those negative interests or those negative behaviors and engaging in risky behaviors. On the contrary, that's really a very small proportion. But the exploration of interest that occurs during adolescence is really very quite positive. This is when young people start exploring, what are their interests long term? Not just their hobbies today, but what are their passions? What sort of impact do they want to make in life? That, your life impact and your cause really starts happening or developing then. So it's an opportunity to, yes, go in one direction, but it's also an opportunity to go in another direction and be able to sort of, with this plasticity and pliability, track or formulate certain paths that are more positive. In essence, it's a crucial time for holistic development, laying the foundation for a fulfilling and positive, successful adulthood and future to come. So what is the status of adolescents' health? Again, there is the misconception that adolescents are healthy. Yes, adolescents do not necessarily have disease conditions, right? So they don't have chronic diseases yet. Most of the time, there is a small proportion of young people that have chronic diseases. But are they healthy? That's a different story. Are they well? That's a different story. And we heard from Dr. Ayyubi a while ago about health and wellness. So if we look at, health broadly, so not necessarily disease, but health more broadly, and we look at the causes maybe of death amongst young adolescents globally. We have the global, then we have what's happening in the high-income countries, and in this classification, this analysis conducted by the World Health Organization, Mamlaka is obviously part of the high-income countries, and we are in that modified region. The most common causes for death for adolescents, and we'll focus on the girls on the right, are road injury and self-harm. so road traffic injury and self-harm, preventable issues, and then this is followed by drug substance use disorders and interpersonal violence, especially in the older adolescents. When we look at causes of morbidity, so not death, but illness or disability, the most common causes for morbidity for adolescents are mental health problems. Again, so we're looking at the high-income countries where we fall into mental health problems, particularly anxiety and depression, followed by some of the behavioral disorders and some of the musculoskeletal problems, and then for older girls, the gynecological diseases. I need to mention a point about young people with disabilities because, again, there are certain vulnerable groups which we don't want to leave behind. Young people with disabilities are at even further risk of certain conditions, such as being exposed to abuse and different kinds of abuse, as well as to bullying amongst their peers and mental health problems. If we zoom into the kingdom, and look at what is the status of health in our young people. And Dr. Baha thankfully mentioned Dirasat Jiluna, which is a national study on adolescence in the kingdom. And this is by far the largest epidemiological study on young individuals in the Middle East, North Africa region. And this was done, so when I conceived the study back in 2007, the reason, the drive for conceiving this was multifold. But one of the reasons was the fact that we did not have any data in the country for young people. We simply did not know. Data is grouped up into below 15 and 15 and above, and it's not disaggregated, so it's not split down or disaggregated. So we can't really make much sense of what that means for young people. So there was always a gap when it comes to the Ministry of Health, when it comes to the global repositories with the WHO, the UNICEF, and so on. There was always a gap when we looked at indicators relevant to young people in the kingdom. So this was one of the reasons that I thought would be important for us to really figure out what's happening, what are the needs of our country, of our people, so that we can programmatically, based on the evidence, generate policies and programming. And so the findings that we found are not surprising, okay? So obviously we have a lot of, this is looking at risk, not death causes, is look at risk factors. So the risk factors that we found are not surprising. Nutritional problems, lack of physical activity, exposure to bullying and to violence, substance use, much lower prevalence. But then we also looked at some conditions, mental health problems, weight problems, whether it's overweight but also underweight, which we sometimes forget, and sleep deprivation. And the most prominent things for females that I'd like to point out in our local population are so significantly different in females in comparison to boys were number one, solvent sniffing. So like الglue, petrol, benzene, solvents that you can sniff for getting a high. And this was surprising because this was quite higher in girls in comparison to boys, and we think it's because from accessibility perspective they're more accessible. But we never talk about that, right? Secondly, mental health. Mental health problems were twice as prevalent in girls as compared to boys. Now, the higher rates in girls is a global phenomenon. In the Middle East, generally that gap is bigger, with girls having much higher rates than the global rates. And sleep deprivation. Girls were 20% more likely to be sleep deprived, not sleeping enough, as boys. So we talk about often in health system, when we talk about health, we talk about conditions, disease conditions in adulthood. You know, we're suffering these chronic diseases. What do we do to treat them? What to do to take care of them? Well, 2/3 of premature death that occurs in adults is because of behaviors that began decades before in adolescence. So the money is really investing in these young people to prevent these behaviors and these sort of factors from beginning, so that we avoid these disease conditions later on in life. So health services in the kingdom, we have a lack of dedicated health services for adolescents. So our practice is either pediatric driven or adult driven, and that age cutoff is 14 years. So you can imagine at 14 years, a young boy or girl, which we're talking about today, is transferred to adult services. So a young girl with chronic disease condition is a young girl with, let's say, menstrual problems, is transferred to adult services where she is receiving care amongst postmenopausal women by adult providers. It just doesn't, just try to imagine that. And when I first started my adolescent gynecology clinic many years ago at the National Guard, this was a really big relief for many mothers and their daughters, because their daughters have been suffering from, for example, menstrual problems, and they didn't know where to go. They go to adult providers. It's not the right setting. The training is somewhat different. They go to, children's setting. It's just totally not within the norm. And so our cutoffs are misaligned with national regulations. As a country, we define children as anyone below 18 years of age. If we look at the Child Protection Act, if we looked at Nizam al-Ahdath, it defines a child as someone below 18 years. In the health system, we're not aligned with these definitions, and here this creates lots of mismatches on different fronts, which you can imagine. We're a very reactive health system, treating disease, not health. We're a sick care system, not a health care system, very fragmented in terms of the disease, the patient or the person journey across the spectrum, and we lack the required capabilities. So both within the different providers' settings, whether they're professionals that treat young people or treat older people, the training or capability to treat adolescents per se and youth per se is largely missing, again, from our education curriculum and beyond, and let alone sectors beyond the health sector. And then we have different, there's a lot to do with generalized versus specialized services. We heard about wellness from Dr. Ayubi this morning, and I thank him for making it easier for me to address this. But now let's think about beyond wellness. So moving into well-being. And you need to have wellness, health and wellness, in order to be able to achieve well-being. And well-being is really at that sort of ultimate stage of self-realization. So adolescent well-being is defined as adolescents having the support, confidence, resources to thrive in context of secure and healthy relationships in order to realize their full potential and full rights. And so this is the adolescent well-being framework that was developed back in 2020. And you can see there's 5 pieces to the puzzle. Health and nutrition is only one. There's 4 other pieces in order to achieve well-being: connectiveness, positive values and contribution to society, safety and a supportive environment, learning and competence, and agency and resilience. And it's really these 5 pieces of the puzzle make up well-being in the context of the individual, at the community level, and beyond. It's chopped off at the top, but at beyond, meaning the culture and overall legislations and policies of a country. So that whole ecological framework. We talk about risk factors, risky behaviors. Let us flip that and have a more positive look and talk about protective factors. And protective factors, this is an area of deep interest, research interest of mine, and protective factors looks at how do those factors that really encourage and sustain positive behaviors. And we're very fortunate in our own culture that we have a very, very important protective factor: family. And this has been shown by evidence, international evidence, as well as our local evidence, that this is a protective factor on multiple fronts. Let us make use of this and capitalize on that. So looking at, when I came to do my PhD dissertation, I was looking at all of this work that I've done over many, many years. And what is really the main sort of message, or what is the important lesson learned? And it really is looking at addressing the complexity and the interconnectedness of all that's happening. Meaning we address certain, specific health conditions or disease conditions, whichever way you want to look at it. And we address those sort of like in verticals, independently. That doesn't work because all of these verticals are very much interconnected. And that's really what you can see here. Those items in red are those verticals, if you will. but you can see how they're connected to everything else. And so relationship with parents, again, as a protective factor, protects against bullying, against violence, protects against mental health problems, sleep deprivation or lack of, protects against, other conditions. And so let's shift our focus from looking at certain entities or diseases or conditions and look more holistically, more broadly. Adolescent health is certainly key. It's a hot topic on the global health agenda. It's been a hot topic for the past, since 2016, when the UN the UNICEF issued the the Global Strategy on Women, Children, Adolescents Health. So the global strategy was always looking at women and children's health. For the first time in 2015, 2016, it was women, children, adolescents health. And since then, more and more traction has been gained on this topic, being addressed at UN General Assemblies and whatnot, because of the understanding now that achieving adolescent health is key to achieving the Sustainable Development Goals. If we don't achieve adolescent health, we cannot achieve the Sustainable Development Goals because it is cutting across so many of the different goals. And that cross-sectoral approach, or this intersectionality, again, is very key. So adolescent health and well-being is not just limited to the health system. It cuts across so many different sectors. And the beauty of a forum like this is that we have people from different sectors, coming together so that we can address this more comprehensively and more holistically. So you can, see here if we look at the SDGs, so many of the targets for beyond health, beyond number 3, are linked to adolescent health. So this is why I'm saying we need to achieve adolescent health in order to be able to achieve the Sustainable Development Goals. So moving on from health to well-being, interventions for adolescents need to operate at all levels, vertically across the ecological framework, and from the individual to the structural level in a cross-sectoral manner. So I'll say there's like a 4D lens, the way I see it. It's a 4D lens, which I can discuss later, but there's multiple lenses too, or verticals and horizontals and, diagonals. The most powerful gains for adolescent health comes from this multi-sectoral action. And in order to reduce the burdens and risk factors, we need to have an adolescent responsive health system. This is key to achieving universal health coverage. Adolescent health and well-being in all policies. We talk about health in all policies. Many of you have heard of the High Ministerial Committee of Health in All Policies. Adolescent health in all policies, again, is something I've been advocating for, if you look at some of the research for years. Health in all policies is not sufficient because we look at health broadly, looking at populations, and we tend to forget certain groups. Adolescents are one of those groups, which I'm sure you would defer to. We need to move on to addressing adolescent health and well-being in all policies and have that concretely or explicitly stated. There's a tenfold return on different fronts by every dollar we spend in adolescent health. So adolescents are not children. They're not older children or younger adults. They have particular health needs. They have a fundamental right to health, and they bear that substantial proportion of disease burden. And the investments are multifold from an economic, but also from a social capital, perspective. So coming back to the triple dividend, what does that mean? If we invest in young people's health, we have the triple dividend meaning that it will positively impact young adolescents themselves today. It will impact their future adult lives because you ingrain these things that will continue with them, inshallah, for generations, decades to come. And benefits for the next generation as they become adults and parents themselves and sort of, again, begin to role model and that, that cycle of life, continues. So with that, I conclude with these following recommendations. We really need to invigorate a national commitment to adolescents and their health and well-being and explicitly address this throughout cross-sectoral policies, particularly adolescent health and well-being in all policies. Number two, when it comes to healthcare services and health services, we need to redefine and to expand child healthcare services to be child and adolescent healthcare services that is inclusive of individuals until 18 years of age, meaning increasing that age from 14 to 18 in a developmentally appropriate manner. And that is specifically addressing the needs of our young girls, and in a way that is evidence-based and responsive to adolescents' health needs in order to achieve universal health coverage. We need to build multidisciplinary capabilities and capacity across the different sectors. Within health, it's very obvious, where that gap is from a capability perspective, but then there's also further capacity building that is required across the different sectors: education, social, so on and so forth, so that we can enable and empower really professionals to provide the required care and preventive programs to support young people effectively. From a data and a research perspective, we need to explicitly address adolescents in national surveys and data collection. So not lump them up with younger children or with older adults, but explicitly address them, again, because their needs are different. And align that with the global indicators that have been developed. And finally, we need to provide and scale up awareness and educational content about adolescents and their health and well-being, targeting the different stakeholders, the young people themselves, parents, caregivers, and professionals across the different sectors. With that, I thank you for your attention.
Thank you, Dr. Al-Hajri. Thank you, Dr. Al-Buhayran for this informative lecture. Both speakers, they took us into two different domains: the adolescent, the young woman health, and the mature and menopause woman. And both have indicated that these two areas are really important because of increasing life expectancy and wellness. The menopausal number of menopausal women and that need specific services will be increasing, and this is important. And at the same time, adolescent health is really a demand in the country, specifically that we are still not really unifying the age of adolescent, whether it is, although some of the legislation, as Dr. Fadia mentioned, identified children as less than 18, but still some of the policies, they are still not really identifying this specific stage. And we really need the policy that reflect the health of mature women and adolescent women. I open the floor now for a question, and we can take the last one there, and then this one here, and then this one. Three. So we have three questions. Last.
Assalamu alaikum. Thank you for the great talks. The talks by Dr. Fadia really spoke to me. When I see them in the clinic, I'm an adult neurologist, so when I see patients coming to me as pediatrics to adult, I really can't work with them because I'm treating them as young adults rather than adolescents. So that doesn't really always work. The second thing, from the point of view of all the factors you mentioned, it does really affect their brain health, and I can tell for sure that their future lives are going to be impacted because of the stages of these factors. I also work with young people, and on the surface, they all speak about these factors. They say they have stress, some wellness issues, sleep issues as well, and no one really knows where to go. So if we really have a young population and that's helping us produce a lot of work, then we also need to look at adolescents to continue to develop quality youth, to continue to build the future. So my question is simple: do we have enough adolescence professionals? And do we also have a pathway to produce more? And do adolescence clinic are the only solution? Or should we do other interventions to produce better adolescence health? And
thank you very much. Dr. Fadia?
Sure, thank you for that. Very important question. So the short answer is no, we do not have enough. And again, it really depends on how you look at this. So you don't necessarily need adolescent medicine subspecialists to treat all of these conditions. Adolescent medicine specialists, we're only 5 in the country. Okay, so We can't even have one person in each region of the country. And unfortunately, there is no pathway, as far as I know, in place to build further capacity. And that's really where this recommendation for building capacity comes from. Having said this, you don't necessarily need adolescent medicine subspecialists to treat all of the common conditions. And this is where the importance of building capacity amongst the generalists comes in. So as pediatric providers, as family medicine providers, as adult or internal medicine providers, what can we do to build further capacity in those professionals who can provide more general care and treat some of the common things? You will need adolescent medicine specialists for specific subspecialized problems. As an example, eating disorders, some of the gynecological issues that we see with reproductive health issues that we see with young girls, and others.
I think as a child protectionist and expert in evaluation of sexual abuse, I really suffer a lot from, in the private sector, from evaluating pediatric gynae. We do not have really enough specialized pediatric gynecologists that evaluate adolescents for their gynecological problems. So I do agree with that. Second question here.
شكرا دكتورة مها، شكرا دكتورة نشمية والدكتورة فادية. أنا أحمد المحميد، محامي ومستشار قانوني. جبت معي اليوم فريق قانوني، المحامية وجدان السالم، والقانونية فادية الدلبحي، والقانونية الأستاذة ملاك المانع. كنا ناويين نسوي فايتنج هنا. فشكرا دكتورة مها لك وللدكتورة نشمية. هل تؤيدون وجود بروتوكول للحماية الوقائية للأمراض سواء للسيدات أو للأطفال؟ لا يوجد لدينا أي بروتوكول حماية مسبقة. يعني الرياضيين ما يلعب الكرة اللي هو عنده فل لياقة. حتى وزارة العدل الآن القضاء ما تروح للقضاء إلا أنت مسوي بروسيسنج معين يسمونها حماية وقائية وصدرت فيها حوكمة فعالة. في المجال الطبي هذا لم نراه. الدكتورة فادية مشكورة، أنا مؤمن جدا بفكرتها من أيام الحرس الوطني، كنا نتخانق احنا وياها بهالمجال. أتفق معك أنه 18 سنة هو سن الطفولة، لا يوجد ما يمنع أن يكون حتى في المستشفيات. فقط المطلوب أنه المستشفيات هي تبادر وتضع بروتوكول لهذا الشيء مع حفظ الخصوصيات والتفرقة بين التكلفة الشرعية أو التكاليف الشرعية عن النواحي الطبية. أنا أتفق معك تماما، ولا يوجد ما يمنع لا نظاما، وأعتقد إن شاء الله أنه لا شرعا. شكرا جزيلا.
شكرا دكتور أحمد محميد. دكتورة نمشة, if you can really answer about الحماية.
السلام عليكم. it's working. صحيح كلامك دكتور، صحيح كلامك. في كثير الحين دخلت علينا فحوصات ما قبل الزواج يمكن من around 10 سنوات. كانت في البداية فحوصات قليلة تشمل أشياء بسيطة، قد تكون أمراض وراثية. الحمد لله lately دخلت فيها أمراض sexually transmitted أو أمراض تنتقل جنسيا. لسه ما هي كاملة، ما هي فل، مو كل الأشياء اللي قد تنتقل جنسيا، لكن إن شاء الله نقول إن إحنا في الطريق. هذه الأشياء تحمي مستقبلا. يعني كثير تمر علينا في العيادات، يمكن زميلاتي في النساء والولادة بعد الزواج تجي المرأة نفحصها، هذا مرض، طيب إيش أو هذا infection, what is it? Is it sexually transmitted? هو next question على طول، هذا يعني كيف جاني؟ مرات نقدر يعني نقول لها مباشرة أو زوجي لازم يتعالج. يعني السؤال بطريقة ثانية، زوجي المفروض يتعالج، ما راح تعطيني علاج لزوجي؟ كانها تسألنا is it sexually transmitted? Is he the source or where is the source? طبعا هذا يسوي لنا مشاكل كثير ويقعنا احنا تقلب الاستشارة من استشارة طبية إلى محاولة إصلاح، إلى لا قد ينتقل بطرق قد، وأحيانا ما عندي إجابة صحيحة أو إجابة مباشرة، أو ما أقدر أجاوبها إجابة مباشرة لأني هي بتطلع وبتبحث they will create problem، وممكن المرة الثانية تجي وزوجها يعني تصير جلسة صلح أو جلسة محاكمة عندي. فأيوة ليتي يصير في بوليسي إحنا يساعدنا الجاينيكولوجيست، إحنا ما نواجه هذه المشاكل لحالنا في العيادة وما نقدر نتفاهم معها أو ما نقدر نحلها.
And I would add just one point that the national legislation are improving, yet there are certain policies in the Ministry of Health is still lacking these problems. That's, like when we are dealing with STI or sexually transmitted infection, when to tell the partners and etc. So we don't have really clear policy. And I think if there's anybody from the Ministry of Health, I would really appreciate if they are really, and I will give you the microphone after that. Doctora, do you want to add anything about the age of the child in the health sector?
Just very briefly. So طبعا this has been وسعيدة بشوفتك أستاذ أحمد. طبعا the age limit has been in discussion for many years في القطاع الصحي. Back in I think 2014 it was في المجلس الصحي السعودي. That's when they increased the age from 12 years to 14 years. الآن we are actively having the second round of discussions. We need to provide our feedback by the end of February, inshallah. And we are discussing again the further increase of age limits from 14. طبعا I'm very actively pushing for 18. That's not a surprise. So we are working towards that. We will be submitting our recommendations as a group. يعني established من المجلس الصحي السعودي by the end of this month, and then it will go through the natural sort of chain of command from the health sector perspective, and obviously your support and everyone else's support will be very much appreciated. شكرا.
I'm very glad that we have a committee that really addressed this issue at national level. We have one question here and then we'll be here.
Assalamu alaikum. Khalid Shami from King Faisal Specialist Hospital and Research Center, but I'm in the administrative side, not the medical side. So thank you first of all for the two great presentations that has a lot of information, and it's really. But one of the information that was really shocked me when you mentioned, Dr. Lina, that the most cause of the adolescent death is the mental health, not the car accident, not the other diseases. This has really shocked me. So if you can elaborate more, what are these mental health problems or causes that would cause to death for our young children? Because it's really scary for me.
Thank you. Can we have the question here and then I will let you answer both?
Assalamu alaikum.
Here. Can we have the question here and then I will give it to you back?
It's actually a short comment on Dr. Fadia. What she said is very insightful about the adolescent medicine. As a clinician, I'm aware of the problem that arises from the definition of pediatrics versus adults. But I see a bigger problem here. There's a loophole in the structuring of the health system, and you alluded to that in the last slide. Because in the current model of care, we have 6 systems of care, including well-being and women's health, but none of those systems of care touches on adolescents. And so we need to be cost effective, and we need to be cognizant. If we're going to spend our money, we have to spend it where it should be. So if we have a problem with 15% of our population and it's not taken care of within the current system of care, we need to overhaul and restructure. So this is very interesting, not only from the clinical perspective, which I'm aware of, it's also very valid and relevant even from the legislative point of view. And I think from my position in Shura, we need to rethink this and reinvigorate because the interventions that have to be to cut across the system of care, they have to include adolescents because you cannot treat them as adults and you cannot treat them as kids. So I just wanted to re-emphasize that point, and it's very interesting because we could do something about it from our perspective.
Thank you very much. Let's have another 2 mudakhalat, and then I will leave the last comment by the speaker. Dr. Muna Al-Mshait, and then Dr. Muna here. Okay. And make it short, so because we have a lot of hands raised.
Okay. أود شكرا our distinguished speaker. الموضوع من أهم المواضيع اللي دائما نواجهها في العيادة. إحنا as a gynecologist this especially from the younger girls, the adolescents, they are coming to us because يعني this age يعني thanks for highlighting this great talk and session. The most important for the most important age group, which they are pre, post menopause, and the adolescent, the forgetting age. Usually, this patient they find difficult to consult which doctor and which clinic, and who will accept them even. Finally, they come to the gynae clinic. If I consider more about the pre and post menopause, really they are suffering because of the limited interventions and treatment. Treatment are not easily found. Even in the government hospitals, it will not be available, and in the private, also there is it's difficult, and usually it will not be covered by the insurance. This is المجلس الصحي السعودي ومجلس الضمان الصحي يعني نحتاج منهم دعم كبير من ناحية العناية بهذه الفئة العمرية، خاصة مرحلة النضوج للسيدات يعانون بشكل كبير ولا يوجد ما يساعدهم. ف even the treatment لما تكلمنا عن HRT treatment hormonal replacement therapy، الآن اللي موجود الفود supplements حتى even هذه it's not available in the market easily. الآن اللي نحتاجه إنه recommendation and to make more attention to providing the service for this age group, and who's responsible about this age group, and how we can help them, how we can help the health system to take care of them. Thank you.
Thank you, Dr. Muna. Let's have another 2 comments, and I will leave the last comment by the speaker. دكتورة هنا معلش أنا آسفة تأخرت عليكي, and then الدكتور at the end here. Just الدكتورة أول بعدين.
السلام عليكم. دكتورة ندى منشي، مديرة قسم الوقاية من سرطان عنق الرحم وفيروس الورم الرحيم البشري في وزارة الصحة. حبيت بس الدكتورة مها قلتي على موضوع السكشوال. أنا تخصصي preventive medicine and sexual and reproductive health. Since I came back from the States, one of the important tasks that I had and I led, which is including HPV to the vaccination of the adolescent girls. Alhamdulillah, we established that in 2022. And now the age group is much higher. We can give through the primary health care centers and MOH till 26, from 9 to 26. Any girl, any female can go and get the vaccine. So we did something in the STDs areas. Inshallah, we're going to do more in that. And the screening, okay. Inshallah.
Thank you very much. We'll get the last comment from the end here, and then we'll conclude.
صباح الخير. الدكتور منصور الهجلة، محامي، وسابقا كنت نائب الرئيس التنفيذي للتشريعات والأنظمة في برنامج تحول القطاع الصحي، كذلك يعني في التشريعات الصحية بشكل عام منذ فترة. فعندي بس فقط تعليق بسيط، وأشكر أولا المتحدثين الزملاء، خصوصا الدكتورة فادية تحدثت عن موضوع جدا يعني اللي هو المراهقين، وموضوع معقد. فأنا ودي أجاوب على موضوع اللي هو الجواب على سؤال أحيانا تيجي حالات ما ندري إيش نعمل فيها. فأنا أعتقد أنه دائما يجب أنه ما نتعامل مع كل إشيو إنها مشكلة تحل بوجود policies. أحيانا policies تكون معرقلة. ليش؟ لأنه مو كل الدومينز اللي نواجهها من مشاكل هي in order، يعني منتظمة ونستطيع أن نجاوب عليها بpolicies. أحيانا في complex domain which is no relationship between cause and effect، يعني نحتاج أنه نضع تجربة وتستينج وبروبينج ويحتاج أنه investigating more، بعدين نحتاج أن نتدخل بشكل دقيق ونشوف الأثر. يعني أحيانا case by case، وأحيانا personalized يعني issue you have to deal with. فأنا أشوف أنه مو كل issue مرتبطة بالبوليسيز، فننتبه أنه مو كل القضايا اللي نواجهها مع المراهقين، حتى أيضا في قضايا اللي هو سن اليأس وما بعدها، أنها قضايا واضحة لكل الناس أو واضحة لكل طبيب. I know أنه الأطباء في الغالب يدرسون يعني دراسة انتظامية وعندهم انه كل شيء له علاقه بالسبب والنتيجه، وانه في الغالب انه يحاولون ايجاد جواب، لكن احيانا ما يكون عندك جواب. اذا لازم تكون اول شيء اما انك توسع مداركك في تنوع المشورة من خلال خبراء آخرين، أيضا يكون قريب من الحالة وتستنج كل تدخل. فأنا أشوف إنه الموضوع مو دائما، أنا يعني أخشى دائما من كلمة كل شيء نحتاج فيه إلى policies أو نحتاج فيه إلى regulations.
Thank you. I mean, this is a very important point, but we need to change the culture of the health sector in Saudi Arabia, because we are really dependent a lot on policy, and a lot of physicians, they refuse to take an action if there is no policy. So it is easy said, سعادة المحامي, لكن to implement it in a culture of health sector that is dependent on policy is very difficult. I would really leave the last comment by the speaker, Dr. Namsha Al-Hajri. If you can comment, if you have any comment or any addition.
طبعا شكرا لحضوركم ونتمنى دعمكم لصحة المرأة الناضجة. زي ما تفضلت الدكتورة المشيط، نبغى one stop shop لصحة المرأة. ما نبغى أو الأدلسنس حتى ما نبغاهم يعانون وين يروح وين مرجعي، ودعمكم عشان توفر الأدوية. حتى الخيارات زي ما تفضلت في فيتامينات، في خيارات آمنة كثيرة. الخيارات العلاجية اللي متوفرة قليلة. نحتاج نساعد المرأة for quality of life. حتى الناس يعني في نساء يعانون بصمت، she don't want to be labeled as menopause مع انه it's not a stigma. وفي ناس they speak up now. I need to continue my life. It's quality of life. احنا نبغى النساء في عمر 60 وال70 يصلون واقفين. ما احتاج اكون قاعده على كرسي. I need helper. ابغى اصلي وانا واقفه. ابغى صحتي تكون ممتازه. ما احتاج مساعده. فاحنا هنا نتكلم عن quality of life. احنا ممكن نعيش 20 سنه واحنا نعاني، وممكن اعيش 10 سنوات وانا عندي كل الكاباسيتيز اقدر اعيش زي اللي عمرها 20. فمن هذا المنبر يعني we want your support for mature women health for the best quality of life. Thank you.
Thank you very much. Dr. Rafida, your last comment.
Thank you. So maybe just to clarify the point that was raised. So the highest cause of death is road traffic accidents. So in high-income countries, road traffic accidents followed by self-harm. Self-harm meaning like suicide. Other mental health problems is the most common reason for morbidity or illness, not death, apart from self-harm طبعا. So that's just a clarification. طبعا thank you very much, Doctor, for your comment. It really is, and the way I see it is, we're talking about the redesign of the health system. It's very much linked to your comment, Dr. Mansour. Just to sort of connect the two, I definitely agree with the importance of policies, which maybe we have a different opinion here, but I agree with you that maybe we don't need to be very specific in certain areas, because there are things that are left, it's better to keep it left more broadly, and then the specifics will come based on, individual institutions' needs and so on. But if we connect the two, what you have mentioned in terms of the model of care, you're absolutely right. That whole model of care does not take into account specifically adolescents. So we really need to look at how do we redesign so that it is taken into account. And that's where the importance of policies comes in. Why is it not there in the redesign? Because adolescents have not been explicitly addressed in health policies. Health policies are addressing broad domains. We need to explicitly address them so that they will be taken into consideration in the redesign and other, interventions. And maybe it will be a matter of time. If they're explicitly addressed, you build a culture where people recognize them, and then maybe 20 years from now, we don't need to be so explicit because it's just ingrained. But in order to bridge that gap, we do need to explicitly address them. I'll end there, Dr. Maha. Thank you.
Thank you for our speaker, Dr. Al-Hajri and Dr. Al-Bhayran. Thank you for your listening, and I we would really like to thank جمعية رفيدة وعلى رأسهم الدكتورة فاطمة الهملان to take the recommendation that was really discussed here and mentioned in the study, and from the audience recommendation to take it into action. And this is what we are really تعودنا من جمعية رفيدة أنها تعمل الفورم هذا ونطلع ب recommendation that can change the legislations and the policy for women health in the country. Thank you very much for your listening. Thank you.
شكرا Professor Maha Limniye for leading the second session. شكرا دكتورة فادية. شكرا دكتورة نمشا. We'll start our third session now. Will be chaired by Dr. Haya Zaidan, Consultant Maternity Health and Wellness. You're welcome on stage, Dr. Haya.
بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. أصحاب السمو والمعالي والسعادة، زملاء الكرام، أتشرف بوجودي معكم اليوم وبالدعوة الكريمة لإدارة هذه الجلسة الثالثة والأخيرة في منتدى سياسات صحة المرأة، وأشكر سعادة الدكتورة فاطمة الهملان على هذه الدعوة. الآن لدينا طبعا نخبة من الخبراء والخبيرات يشاركوننا عدد من أحدث المعلومات والتوصيات في أهم قضايا صحة المرأة، ويسعدني في هذا المجال أن أكون أدير هذه الجلسة تحديدا لمناقشة ما يخص الأمومة والعافية في بيئة العمل للموظفات. الآن يسعدني أن أرحب بضيفاتنا، أن أدعوهم الآن للانضمام علينا في هذه المنصة، سعادة الدكتورة براء ميزي وسعادة الأستاذة سارة العتيبي. حياكم الله. Dr. Bara Mezi is a consultant psychiatrist specializing in women's mental health, and she achieved her degree from the University of Toronto in Canada in 2012. She has worked diligently to establish a sexual health clinic at the Mount Sinai Hospital in Toronto, as well as establishing the first women's mental health clinic in Saudi Arabia in 2013. Welcome. And Dr. Bara will be talking to us today about promoting motherhood through mental health support during pregnancy and childbirth. And Ms. Sarah Al-Utaibi is the founder of Boko Life Consulting and is currently working at King Abdullah University for Science and Technology as part of the Strategic National Advancement and Development for Partnerships. And she has a length of experience in leading strategy and institutional communications, and she has previously worked with Aramco and their transformation team. Ms. Sarah combines valuable American and Saudi cultural viewpoints, and we look forward to hearing from her more about her story specifically in her discussion on health and wellness programs for women in the workplace and promoting productivity. We'll start with Dr. Bara. Welcome, Dr.
Assalamu alaikum wa rahmatullah. Thank you all for attending, and I'd like to start my talk with suicidal notes. So last year in Egypt, a mother of 4 kids attempted suicide, but before that she took the life of her 4 kids, and then she wrote a letter to her husband showing her stories of whatever she was going through. Now, today I'm going to talk about a heart-touching topic, and I think it's changeable. It touches all because motherhood is a very important stage of life, and it shapes our society. I'm going to talk about why is it important to promote motherhood and the difficulties that goes through the peripartum period, the motherhood challenges for women in general and for female residents specifically, and the available services around the globe, and some innovative ideas that can be applicable in our country. So why is it important to promote the motherhood, especially now? Macrotrend, which is the platform for the United Nations, shows a dangerous decline in the birth rate in Saudi Arabia, comparing 1950 up till now 2023. There's a 67% decline in their birth rate among the community. So in 1950, there was 53 births per 1,000 people, and now, 2023, it went down to 15.7 per 1,000 people. What does that mean on the long term? It means that we're moving from a young and youthful society to an aging society within 30 or 40 years. That would have a major negative impact on the community. There would be challenges to social welfare system, the healthcare system, and pension system. All of these need to be adjusted as the number of birth is going down. It has a major economical hazard. So there would be a reduction in consumer demands. There would be economical productivity decline, a shortage of labor, skill gaps, and declining of innovation. Now, I'm talking about money because I know money drives many things, but I want our passion is to drive where the money will be spent. So when we talk about mental health issues during pregnancy, it's the same mental health issues that happens throughout the age of a woman. But why is it important to consider this period of time? Because of the different role a woman would go through. So she's a mother, she's a wife, she's a daughter, she's an active employer in the community. So many aspects will be affected once she is down. So women can go through depression, she can go through different type of anxiety, she would have any kind of psychosis, she would go into severe cases such as depression and suicide. Studies shows that the percentage is really high, okay? So 1 in 5 women would develop a mental health illness during her peripartum period. Now, when I'm talking about peripartum period, it means the time that a woman is willing to conceive or trying to conceive, and then a year after giving birth. So the number is high. 1 in 5 is very high, and then less than 15% actually receive treatment. Maternal depression is amongst the top of the illnesses or the disorders that women go through, but in addition to it is the anxiety disorder. Also, it's high, and a lot of people do not talk about it. Now, one of the things that prevent women from talking about their mental illness is that the stigma and the myths about being a mom and being pregnant and giving birth, that you're supposed to be the perfect mom. You're supposed to be the superhero who can do everything. You should not complain of not being able to sleep. You should not complain that you're getting mad or angry from your kids who are running around the house. So, and that you should be enjoying the journey, which have its ups and downs. So this is one of the things that would cause a burden to a woman. Now, again, mental health illnesses would cause a burden of $40.2 billion in the States alone. Why do women, does mental health disorder happen in the postpartum period? Again, as I mentioned, the expectation and misinformation. So when I think that it's normal to feel tired all the time, and I should not go and ask for help, that would be a big problem. The hormonal imbalance that happens throughout the pregnancy and during the monthly period that woman goes through. The issue of that not every pregnancy is successful. So there would be a 2 to 3% of complication for each pregnancy. There is also the risk of miscarriages and abortions. The lack of sleep that a woman would go through in the first 2 years of after giving birth would also raise the percentage of getting the mental illnesses. Financial burden. So having a baby having his clothes, having his diapers there all the time, and changing of sizes every now and then. The social pressure as well would also affect the financial possibilities in each family. Lack of effective social support. Now, we know that, mashallah, our community is family driven, and we have the social support. Reality is, it's not always the case, because when a woman gives birth, she goes and stays usually at her family house for a month or so. But she would be required to do certain things. She should be smiling all the time. She should meet people who would come to welcome the new baby, and she wouldn't have her own time to have her rest, and would be able to be to do her own things. The other thing is that the difficulties that I see during my work from women complaining that the husband is not helping and is not supporting her during her time when she's tired. And I always ask my patients what kind of support you want, because there are different kinds of support. There is psychological support, there is physical support, and there is a financial support. And you can see everyone has her different perspective. So one of the things we teach them is how to communicate and how to ask for the right help that you want, and we know you can get if you learned how to do it. There are a lot of studies that was done also in the kingdom regarding the postpartum depression, but what caught my attention is the increase of the postpartum depression in big cities such as Riyadh, Jeddah, and Medina. And we also have a fourth column that doesn't show, also in Dammam. So the prevalence goes between 40% going down to 30% is the minimum. And we can see now the internal immigration of people from different cities toward large cities. And that would lead us to a mono or a nuclear family. So we don't have the extended families as we used to. So now we see a lot of people coming from the south or north to Riyadh without their families. So they're solo by themselves. What's the difference between women's mental health and men's health and men's health? The major thing is that the different roles that is expected from female, different responsibilities, and her different needs. And I think I'd like to focus on the issue of justice more than equality. We don't need equal rights with males because we're different. Okay, we need to be considered as females. I always tell my student, my resident that I train, that don't give up your right as a female. So من حقنا نتدلع, من حقنا نتنغنى, من حقنا to be considered that we have our own physical needs. احنا we do move يعني كنب ودواليب في الغرفة ونركب ونفعل, بس احنا نحتاج الدعم from the other side, from our partners, from our families. And now also with the changes in our community, we started seeing the single mother working, taking care of her kids. This was not an issue a few years ago, but now we can see it raising on the top. We also see girls who are moving out of the houses of their families and living by their own, and now they're starting to have financial problems and stresses related to this. These are all our new things. The other thing, as Dr. Fadia mentioned, the substance abuse. This is something, again, we would rarely ask before. And now we should ask it with every single patient that would come to our clinic, whether male or female, but we have to ask that because it's more available than before. Why is maternal mental health is very important? Again, it's not only the mother, it's also how it would affect the baby. So a lot of studies shows that when the mother is pregnant and she's having whatever mental illness, what we're sure about is that it has a negative impact on the baby. The baby's development will be less than the other children. There would be changes in his brain function and brain structure. His epigenetics will be affected as well. his cognitive abilities would be different than a baby who's born to a healthy mother. After the baby is born, there's something that is called bonding. العلاقة بين الأم والطفل. It's not an easy thing to develop, and people think that it should be automatic. And when someone goes through a process where they cannot have these feelings because their plate is full. فأنا already depressed, I cannot be engaged with my child who's crying and he has his own needs. So what happens is that these kids would develop some behavioral difficulties. When they go to school, they don't have enough social skills to deal with difficult kids, with bullying, and being able to process how they should face the issues they have. Also, studies shows that these kids will have metabolic dysfunction. We can see the increase in the weight in this certain children. So, what are the available services around the globe supporting motherhood? Now, while I was discussing with Dr. Haya yesterday, I wanted to emphasize on the things that we don't have, because we have a lot of amazing services here, alhamdulillah. But I'd like to focus on the things that we don't have, and to get it, it would be so easy. It's only a matter of justification. عمر بن الخطاب said الحكمة ضالة المؤمن أن وجدها هو فهو أولى بها. So a lot of us were studying in the States or in Canada or in Europe, and we saw that different centers have a mother-baby unit. Okay, so these are some of the examples. So what does a mother-baby unit have? So the structure of the unit is almost closer to what we have here in regard to the capacity of the room. It also needs additional things. So such as a play area for the kids to play, a gathering area for the mothers to stay with their kids around. Now during these units, there are trained nurses and social workers who would help the mother during her parenting phase with the baby in different age. طيب يعني ما في age معين, لكن إنه usually it's by the age of 6 that a child could stay with the mother. Afterward, usually they are more independent. 40 years ago, or more than 40 years, I remember we were in the States and my mom had a mom and brother. We were only there in the States, and they allowed me to stay with her in the same room. This was a government hospital. And I remember how my mother was talking about the relief, that she was extremely worried where can she put me, especially I was a clingy child. So it was a relief for her and my father as well. Now, this is impossible here. There's no way. Even the husband sometimes not allowed to enter. So I think this would be an easy shift in the services that is provided, and it can make a big difference. The other thing is in such settings is that if you can see the group of ladies at the back, all of these are patients. What they do is that they provide social support, and they would help the mother, giving their experience in how the things they face and how can they deal with their kids. So this is an extra bonus to such settings. So the benefit is that it improves the maternal mental health. Now, these units are not only for psychiatric patients. So it's a general setting for whatever, whether the mother is sick or the baby is sick. Again, it helps enhancing bonding and attachment between the mother and child. It reduces healthcare costs basically by being able to detect early disorder or early illnesses. It improves parenting skills, and it has a long-term economical effect. So on the short term, there is an initial operating cost, but later on, there is the other things that improve maternal health, reduce healthcare, and lower healthcare utilization, and positive child and population outcome. This last part I think is very important, because once we have a stable child, we know that we're going to have a stable adult and less problems with the government, less problem at school, and better productivity. So it's on the long term, it's a win-win situation. So I'm proposing some of the feasible solutions which is having a mother-baby unit, a breastfeeding-friendly environment. I saw it only in King Khalid airport, which I really, my eyes was almost watering. It's a nice thing. We have it in some of the big malls. However, I think it needs a little bit of improvement and maybe more frequent rooms. Support groups. So Rufida was, I think it was the pioneer in providing the support group. I was working with it last year through a virtual group, and this year, mashallah, they're continuing, and I'm sure they will continue. However, the need is much than what is offered now. The number of women who are willing to participate is really high, so we need more support group and we need more advertisements for such groups. The fourth one is something that I saw while I was training in Canada, is that they provide an in-house night care for newborns by well-trained nurses for the first few weeks. And it's free from the government, and it has to go through a number of processes before the woman goes into birth. And this would help that ease the pain of the woman, and she would be able to sleep at night, and next morning she would be in a good health. Plus, this nurse would help the woman in parenting and being able to adjust, also teach her how to breastfeed the baby. So again, this is an additional bonus. The fifth one is the innovative one. Now, this was in 2004 while I was, or maybe 2006, during my residency here in Saudi Arabia. So I was working at the military hospital, and we had a patient who was schizophrenic. She got married while she was in the prodromal phase. So actually nobody knew that she's gonna become schizophrenic. Few months later, she got pregnant, she had the baby, she was totally neglecting the baby, not because she's a bad person, but because she's schizophrenic. She does not realize which is right and wrong. And the husband was extremely frustrated that her family were lying to me, she's sick, I want to divorce her, the baby is not good, I don't know where I'm gonna put him. And this social worker came up with a brilliant idea. So she got one of her patients she was following, and this lady was in Dar al-Musinat, I don't know what it's called in English, for Dar al-Musinat, senior residency. So she got her, and she let her stay with this family at home. She was taking care of this baby. She relieved the husband and the wife and the families from this burden. So I think this would be a new way of, a new service that can be provided. Plus, we're having the stagnation of those people in these houses. So if we get a group of those women and we train them well, and then they're available for these families for a year or two, and then they can move on to other families or may be able to continue there. So I think it's a very nice and innovative idea by our social worker. Actually, I don't remember her name, but I think she did a great impact in the life of this family.
Dr. Rabara, if we could just, conscious of time, to just kindly summarize. Absolutely. That's all right. Thank you.
The last thing is the social support by the family and society. Now, I just go quickly about the burden of mental illness on or the motherhood for female residents. So I'll go quickly because I don't have time, but data shows that Saudi Arabia has more female neurosurgeons in comparison to male, which is an astonishing information, which bring me to a question of, I wonder how those women would be able to have children and how they would be able to get pregnant, they take care of. We already know that male surgeons are busy. Current regulation in residency and fellowship does not guarantee certain things. So they don't have maternity leave. Female residents do not have breastfeeding time, and there's no parental leave for their husbands if they're specifically male residents, and they only have the option of either a 1 month freeze or they would drop off the program. So I think changing the regulation of this would make a difference. Now, Australia has flexible working arrangement up to 18 weeks paid parental leave. Now we're talking about residents, not doctors, okay? Norway had 49 weeks of fully paid leave, and they have breast-friendly environment. And in Canada, they would have up to 15 weeks of maternity leave, followed by shared parental leave up to 35 weeks. يعني تقريبا الطفل يكمل سنتين هو في حضن أمه وأبوه. So these are some of the proposed solution, which is prolonged fully paid maternal leave, limitless number of pregnancy during training. فأنا أذكر قبل ما أدخل الطب واحدة من قريباتي أنا دخلت ophthalmology, and one of the condition of acceptance is that you should not get pregnant during your residency. طيب هذا was true story, and she really kept up herself لما ولدت لما خلصت التخصص وبعدين she got pregnant. The thing is that if you get pregnant, you will be laid off, or you need to drop off the program. Presidents need breastfeeding time and breastfeeding friendly environment, paternal leave if it's possible, and also flexible working hours would be helpful as well. By this, I conclude my session. Thank you so much, and sorry for taking more time.
Thank you, Victoria. Thank you so much. We'll give the floor to Ms. Sarah Al-Attabi. Please go ahead. Thank you.
Thank you, Dr. Bara. I like to move when I speak a little, so I'll use this if it's on. I'll just grab the clicker. Do you want me to set it up? Okay. Well, before I begin, can we please give a round of applause to the Rafida Foundation and all of you as well for being here. Thank you, Dr. Fatma. Thank you. And I'd like to start with a quick question, first of all. How many of you are in the medical profession here? And I apologize, I shouldn't have my hand up because as you can see, I'm not a doctor, inshallah, one day. But one more question. How many of you have ever been a patient? All of us. And that is why I'm here. I'm here as the patient view, not the doctor per se, and I look forward to sharing that with you through this talk. Now, quick overview. My name is Sarah. I am a certified coach and executive coach in health and well-being, and I would say coaching chose me. It wasn't me choosing coaching in the beginning, but it chose me along my journey. And really, I'm honored to be here today with you all and proud to be Saudi, to see these conversations happening now in the kingdom. Before, I would have never thought that this would be something, so thank you. And thank you to all of the women who were speaking before me as well. Now, what we're going to be diving into today are a few of the tactics that I now use when it comes to coaching and consulting other organizations. But really, health as a partnership, the body as a technology, and finally, wellness solutions that we can actually apply to organizations. But first, would it be okay if I shared a little bit more about myself and what brought me to being here today? Is that okay? Thank you. So, this is a nice dark background for us, but it wasn't that long ago that I found myself, and I'm glad to see Brigham and Women's came up because I was living in Boston at the time, but in what I thought was a routine follow-up to a doctor's appointment I had at gynecology. And I remember the day coming into the hospital, coming into the room. I was in the last year of my bachelor's degree, going into my master's and thinking I had the world ahead of me. And when I came in, the doctor looked at me in a way, and I could tell something was wrong. And when I sat down, her voice started choking a little. And I remember thinking, if my doctor's afraid, what's going on? And she looked at me and with tears in her eyes, shared that I had been diagnosed with cervical cancer. In that moment, everything froze. And I had never felt so much fear, shame, and guilt in my life. And I just kept thinking, God, why me? Why did it happen to me? Have any of you ever asked yourself that question? Why me? Yeah. Thank you for your honesty. And then the next question came to my mind while I saw the doctor's mouth moving as she was talking to me, but I couldn't really take it in. How was I going to tell my mum? Now, I usually would take a car to the hospital, but after something like that, I needed to walk. So I moved, and I kept walking, and I think I walked for over an hour, all the way back to my apartment in Boston. And I had this realization. There was one last thing I remember the doctor saying, and she said, Sarah, you're going to go to one of the best doctors in Boston who's working at the Dana-Farber Center, and it's going to be okay. And I realized in that moment, if the doctors were doing the best that they could do to deliver this for me, I needed to step up and do the best I could do for myself and my body and also my life. And that's exactly what I did. So I realized that all the decisions I had made up until this day led me to where I am today, and I was done. I was going to change. And I changed everything. I changed the food that I ate. I changed the friends that I was friends with. I changed the career trajectory I was going towards. I changed it all. And it was the first time I meditated. It was the first time I did yoga and practiced body movement. The first time I actually learned to breathe. You think the first thing we do when we come into this world and the last thing we do when we leave. And this was the first time I was learning how I could use this, how I could increase my immunity, calm my stress. And it changed my world. And I'm happy to say that within the year, alhamdulillah, I was pronounced cancer-free. Thank you. Thank you. Thank you. And I would like to stress that I share this not necessarily to impress at all, but to express that I'm not the exception. There's nothing special about me. And the more I share this story, the more I find that my story is the rule. I have women coming up to me after saying, Sarah, me too. I went through that too. But the beauty of this and what it's created for me is now they say you make your message, right? So in this, now I'm proud to say that I've been able to share this around the world and share this message and the teachings that I've learned by using modern medicine, preventative tools, and stepping up in my role to deliver on my life. Because what a doctor can do for me and show up for me, I have to show up through my whole journey. They're not there with me when I go home or when I need to sleep or when I need to eat. But I am. I'm here. So I'm lucky and privileged to say that this led me into a journey of coaching and working with organizations and people to be able to tap into these skills and share these tools. And they say, you know, you driving in the train and you're building the tracks as you go along. I understand and realize that in science and also in the data, we're running together. But there's no time to wait. We need to start practicing, even if we have limited information and tools now. So after moving through this, one of the key messages that I learned in the doctor-patient relationship, health is a partnership. And during my journey of overcoming this, I became so focused in health and wellness and learning everything I could that I was walking into doctors' offices and they were asking me if I was in the medical profession, because I needed to know if that's one guarantee we have in our life, we have a body. We all experience health and we deserve and need to know how to use that. The reason there's a sunset here is because during that learning, I spent about 2.5 years studying under a Guruji, just because I wanted to learn everything. I said, you know what? Whatever happened led me to this point. Let me see what's out there and what I need to learn. And I said, please, can you tell me, what is the secret? What do we need to know? How can I increase my health? And he said, Sarah, just relax. Sarah, let me ask you a question. When the sun sets and the sun rises every day, right? We don't question it. It happens, yes? I said, yes. And he said, Now, your health that you're concerned about, if the sun didn't rise and it didn't set, would you be here? And I said, no, no one would be here, right? And he said, now let me ask you this question. Do you make the sun rise and the sun set? No, I don't. And that's when I realized there are already systems in our world that are designed for us, for our optimal health. It's just connecting with them. We don't question when we'll next breathe, right? But we do it anyway, and we expect it to be there, and without it, we wouldn't survive. So how do we bring ourselves back into this ecosystem of these partnerships so that we can then partner with doctors to help in our health? That was the question, and moving into the next point is, the body is a technology. This is I tried to do some nice graphics for you, so it was a bit more engaging. But with this, a lot of the question we get is, where is the mind? And we see a lot of images like this, right? So if I was to ask you, where is the mind? Yeah, what we think, right? We would probably point somewhere up here. Well, science has actually shown us that we have over 500 million neurons in our gut, brain cells, and 40,000 in our heart. And that our heart has an electromagnetic current that amplifies this, and actually our heart sends signals to our brain because we experience the emotion first and then we think about it after. So, where is the mind? It's here. All over, right? It's all over us. And it's being able to work with this and understand this and change the way we perceive our health that has really changed how not only I live my life, but the people that I get to work with then live their lives. Another instance of the body as a technology is the European Space Agency also shows us that 5% of our existence is only 5 is physical matter. The rest is dark matter and other things I know that an astronomer can explain to you, but from what I understand, they say 5% physical matter only. But when we look at our bodies and when we understand our life, and as we know, a lot of what happens in nature mimics what we experience in biology. So when we focus so much only on the physical matter, and how do we explain it and how do we see it, what about the things that we can't see? Yes, of course, we try and measure, but we're catching up just now when it comes to the research and the science. So, something like stress, right? And there were a few slides about loneliness too, because I think loneliness is one of the biggest triggers, especially after COVID as well. But we don't have something to measure loneliness right now. But we are measuring stress when it comes to cortisol levels as well. But in this, 75% of doctors' visits are actually stress-related. And this was from the American Institute of Health. And imagine what we can do to support the medical industry if we're able to empower people with basic tools to be able to manage these. Now, it won't help in all cases because there are some stress that's caused by other medical factors. But in this, we can support. And also, I think it's around 70 to 90% of the common risk factor in disease is stress-related. And that UN and the Arab Youth Survey there, I had another one before, that's why. So the Arab Youth Survey here, 70% of the MENA youth are feeling stressed. That's 70% that are experiencing this right now, where we don't have tools and techniques and education for how to develop and use this. With this, we look at wellness models. But with regards to stress, the reason that we bring this up and the importance of it when it comes to stress is actually what we found now in the research of Dr. Tara Swart is that stress is contagious. And it can actually be absorbed through the skin. And I know you've all felt this before when somebody walks in a room and they don't have to say anything, but you can immediately feel something's wrong or they're upset, right? So how do we understand the things that we can't see? How do we measure it? And do we need to measure it just yet, or can we maybe bring some tools and solutions that will help it while we learn? Now I'll jump into the wellness models. So with the work and taking off the patient-doctor hat and moving into organizations, when we look at the relationship and the power of a doctor and a patient, do you also think that those play out in our organizations between our leaders and our teams, right? The leaders and team members have a huge influence on our experience in our workplace and in our life and in our health and in our wellness. So what we're looking at now and merging is really this intrinsic relationship when it comes to the organization and the individual. At the top part of this, you'll see the individual and looking at emotional intelligence and resilience. And what you'll find is that when you focus on the person in coaching and you're able to elevate self-awareness, it has a direct relationship in organizations to their social awareness. And then the same with self-regulation, direct relationship to relationship management. So by actually working with a person on their emotional intelligence and resilience, you get to transform organizations and how teams work together and work with each other. And it's interesting, you know, because we have this concept that when you come into the office and you come into work, you leave your emotions outside, right? You leave the things, you close the door, maybe like a coat, like a doctor's coat, right? You hang it up at the door, and then you focus on work, and then when you leave work, you pick up the coat and you put it on, right? Well, what we found, only 7% of our communication in organizations is actually words. So no matter how hard we try, you say, okay, I won't say anything, I'm just going to focus on the work. 38% of communication is tone and 55% is body language. So as much as we think we're leaving it at the door, it's always with us, right? So really it's how do we allow our whole selves to come to work, our whole selves to show up in our lives, and our whole selves to show up for other people. Let's not leave it at the door anymore. We can bring it in, and it's okay. And how we can do this is looking at this empowerment model we're working with too, which is the 4 key components, and as we said already, awareness, education, incentives, and resources. All 4 of these need to be there in order to have a successful and sustainable model, and particularly incentives. We miss a lot of this and we talk about it as motivation, but we need incentives built into this. Ooh, sorry, do I pull it up a bit? Okay, so we need incentives built into this. Because right now, the way organizations are designed, ooh, is it better if I talk here? Is this better? Is that clear? Okay, I can turn this up. Okay. Is this all right? Okay, thank you. So the way organizations, I'll do this. So the way organizations are designed now is that when it comes to incentives, they're not really there. You're rewarded if you work longer hours, if you take time away from your family, right? You're skipped over, or you're said as not necessarily being committed to the organization, when really you're living a quality, balanced life so you could be there in the organization in the long term. You don't get burnout. So how can we do this? It's interesting because actually in China, a company came out and told their employees if you run 2 miles a day, every day, and they're tracking it with biotech, so biotech wearables, they'll give you a bonus. At least they're trying, which is great. But just as we said today, and as in the medical profession, there are some people who shouldn't run 2 miles a day. And it's actually unhealthy and unsafe. So how do we build these incentives into organizations and into our health policies to really encourage people to take care of themselves? Because as you can see, and I'll go a few slides back, you can see a 21% increase in profitability in organizations when you have inclusion, when you have communication, openness and awareness and emotional intelligence. And it's the same with productivity. So it's a win-win, really. It's just how do we then design this? and really looking at this model of edutainment, especially for the younger generations, coaching, accessibility, and a reward system, using the resources to encourage people and our society to take better care of themselves. So finally, leave you with a quote of what we need is really embracing our whole selves. We not only enrich the lives of ourselves and our family and our community, but we enrich the lives of the future generations, and we allow them the ability to show up as their whole selves in their life and in the kingdom and in this amazing vision that we're building in Vision 2030. So I'd like to say thank you for your time. Thank you to the foundation. Thank you.
Thank you so much. Thank you so much. Do you want me to come over? Thank you so much for those beautiful and very informative presentations. Now we will take maybe a few questions. Anyone would like to? Please, we'll start over there. One question. I've been told that we have only one question. تفضل. حياك الله.
الشكر الجزيل للدعوة من الدكتورة فاطمة ورفيدة وصاحبة الملكي الأميرة موضي وممثلتها الأمير صاحبة الملكي الأمير نوس. الحقيقة عجبتني ملاحظات الدكتورة سارة
انجلي. إن شاء الله soon دكتورة.
لكن أنا I'm 72 years old 72 وتوي جيت من كليمنجارو
ما شاء الله.
5900 متر.
ما شاء الله.
أعتقد المشكلة الكبيرة اللي نعانيها خاصة الومن الآن السمنة. أعتقد أنها هي المرض أو حاضنة الأمراض معظم الأمراض. الشيء الثاني التدخين خاصة اليونج الآن صايرة والمدارس أعتقد إلى الآن لم تفعل الإجراءات الصحيحة لمحاربة السمنة وهذه. فأنا أوافق يعني أن الحركة والسوشيال المجتمع كله الآن يعني في حراك جيد، لكن أنتم كدكاترة وكذا أنا أعتقد تواجدكم في تويتر مهم جدا على أساس الحقيقة البلد يعني خسرت فينا الشيء الكثير أو استثمرت فينا الشيء الكثير ولا بد نعطيه لهذول المساكين اللي في بيوتهم والحقيقة هي سيطر عليهم الكسل ونوع الأكل والجهل. بس أنا الحقيقة حبيت أشكركم واستمتعت في هذا. شكرا.
يعطيكم العافية. شكرا لكم على هذه المداخلة. شكرا لكم. ننهي. طيب الله يعطيكم العافية. شاكرين لكم جميعا مشاركتكم. Thank you so much for all of your insight and your time. Thank you.
Thank you very much.
شكرا سارة، شكرا دكتورة هيا، دكتورة براء. يتفضل دكتور سعود العمر مشكورا استشاري طب الأطفال والمراهقين for a small session.
السلام عليكم ورحمة الله. مساكم الله بالخير جميعا أو صباح الخير جميعا. أشكر لكم هذه الفرصة والدعوة الكريمة. Just to announce that we released الأول برنامج مهني في الويل بينج تحت المركز الوطني لتعزيز الصحة النفسية. البرنامج يعنى بالممارسين الصحيين والاتش ار والتواصل الداخلي لتخريج مختصين في تعزيز الصحة النفسية في بيئة العمل. It is a big issue. البيرن اوت is a big issue. المنتل هيلث والويل بينج is very important في بيئة العمل. فأعتقد وجود مختصين في هذا المجال يؤسسون للصحة النفسية وتعزيزها في بيئة العمل أعتقد أنه واجب وطني بالنسبة لنا نحن يعني نخرج مختصين في هذا المجال. راح يكون بدايته بإذن الله، ما أدري الصورة واضحة أو لا، بس أعتذر صغيرة شوي. هي موجودة في حساب تويتر، سواء حساب المركز الوطني لتعزيز الصحة النفسية أو حسابي. موجود فيه يعني الشروط، شروط القبول وبدايته وكل الديتيلز اللي تخص البرنامج هذا. نحاول قدر المستطاع نحن نلبي احتياج الشركات والمؤسسات والقطاعات الحكومية في هذا المجال. next slide. المعذرة برضو هذه نفس الطريقة. it is too small، يعني we try to expand it، لكن موجودة فيها الشروط، شروط القبول وكل ما يتعلق بالبرنامج المهني للويل بينج. فالله يعطيكم العافية وشكرا على هذه الفرصة. إذا فيه أي سؤال. الله يبارك فيكم. الله يعطيكم العافية. شكرا لكم. الله يعطيكم العافية.
شكرا لكم وألف ألف مبروك. وهذه البداية، يعني أعتقد أي مؤسسة لابد أن يكون هناك برنامج للعافية والويلنس للموظفين. إحنا تعدينا مرحلة الصحة، إحنا نتكلم الآن عن العافية. العافية تمتد إلى العمل، تمتد للصحة، تمتد للكواليتي اوف لايف وجودة الحياة. فأعتقد بوجودكم اليوم كلنا هذا الصوت والأمبليفاي حيكون أكبر وحيكون أعظم الأثر بإذن الله، وكل واحد من جهته حيطالب بوجود مركز العافية، وننتقل إن شاء الله من الصحة للعافية للرفاه بإذن الله.
بإذن الله. الله يعطيكم العافية. شكرا لكم.
شكرا دكتورة سعود العمر، congratulations. من لا يشكر الله، لا من لا يشكر الناس لا يشكر الله. نسعد الآن بتكريم قادة هذا الصباح الجميل سمو الأميرة نورة بنت محمد الفيصل، فلتتفضل مشكورة. Miss Kathy Easter, could you please come to stage for the speaker's recognition? We'll start with اللجنة العلمية, the scientific committee. دكتور منصور الهجلة. دكتور أحمد الأيوبي. خبير رفيدة دكتور أحمد البدر، وتتسلم نيابة عنه الدكتور لبنى البدر. المتحدثين للجلسات the session speaker دكتورة دانية حسين الجارودي، دكتور أحمد الأيوبي، دكتورة دكتور نمشة الهاجري، دكتورة فادية البحيران، دكتور براء مازي، our superhero survivor سارة العتيبي، مدراء الجلسات the session chair دكتورة لميا الإبراهيم، بروفيسور مها المنيف، دكتورة هيا زيدان. ومتطوعاتنا لهذا الصباح الجميل: البتول العسيري، الزهراء القطمة، لمس بيعي، ثانك يو سارة. البتول العسيري ومتطوعاتنا، الزهراء، لمس بيعي، رنيم خالد، جنى عاطف، شهد الجشام، ليان القحطاني، يارا الكناني، سحر الشريهي، سمية الغامدي، إيثار كيال، رزان الغنيم، جود الحيدان. شكرا حضورنا الكريم على حضوركم، شكرا على استماعكم، ونتوقف الآن استراحة الصلاة، ونستأنف إن شاء الله بعدها غداء اللقاء السنوي لبرنامج قادة التحول الصحي. شكرا.